Very often it flows naturally, and what may be construed as compassion in one setting may be deemed as offensive or even rude or even harsh in other cultures. I'm sure we're familiar with that because of all the differences. Maybe hugging someone or putting your hand on their shoulder may just be the natural thing to do. But for some cultures, it may be a little intimate to do that. So there are different understandings, and it's important to have a bit of understanding of the cultural context, even as we move our compassion agenda forward. In terms of just also cultivating trust, it must start with our mindset. A mindset that looks at fairness, a mindset that is committed to action, and a mindset that actually tells the patients or the people we serve, yes, you can trust us both with your care, with your history, and with your needs. So maybe we should go back to our reflection that I shared in the first slide. What has eroded our trust and compassion? What has eroded trust and compassion, not just within the healthcare system, but if you look at the entire society, our people, you know, a lot of things that we hear happening, sometimes you look at the news and you're thinking, oh, someone did something horrific. And you wonder, where are we going as a people? But even within the healthcare system, there are a number of things that one would just pick a few to say they are part of the problem that has eroded the trust and compassion over the years. Socio-political and economic environment. You know, everyone you meet is in this state of almost perpetual uncertainty about what is going to happen next. For example, we are in transition, say from NHIF to social health insurance. Every patient you meet, every support you go to, and we have a number of support groups at Faraja, and people you always ask, so what is going to happen? You know, are they going to pay? How are they going to pay? You know, there's all those sort of uncertainties. And those are part of what, you know, within the socio-political policy environment. Those are factors that make people wonder, what are these guys up to? Why are we changing? Why are we fixing it? And of course, that tells you there's a little erosion of trust as we get along. The media and social media, for that matter, the age of disinformation is also a big factor. And this actually goes to one of the points I put here. When you have centennial incidences in the healthcare system, sometimes things do go wrong in the healthcare systems. You know, we are human, and from time to time, something may go terribly wrong. But once it is picked in the social media or in the mainstream media, and it is played over and over on our TV screens, and you say, how could they do that? How could a woman deliver at the gate of the hospital? You know, so all those things pushed through the social, whether accurate or otherwise, they have also contributed to the loss of compassion and trust. And as I've already alluded, centennial incidences, when they happen, and perhaps those incidences are not managed well, they can just spiral out to a point where people start mistrusting the system. You know, a baby died, or even without having all the facts on the table. And sometimes as healthcare professionals, you know, our necks are just placed on the guillotine, ready to be chopped off. But there's also a lot of pressure on health workers to do more with little time and less resources. I'm yet to come across a healthcare system or an institution that says, oh, we have enough of everyone we need. We always, you know, in your departments, wherever you are, you're always feeling like we are not enough. You know, we are short of this, short of the other. And all those things make us just do the essentials. We may not have all the time to sit and massage the back of a patient. We don't have all the time to just sit with them and provide them with a therapeutic presence that will make them feel, yes, these guys are really compassionate. Wamekaa wamesikiza. Because if you do that in a busy setting, then people, you say you are actually evading duty. Yet that is an important part that should be done and documented. But obviously, we may just focus on the big science, but also competition between providers. We must agree that healthcare is increasingly almost a commodity for sale to the highest bidder. And that is also a factor, because then they say, wanataka tu pesa zangu, even when a test is necessary. Even when you're being told you need to have this MRI or to have some blood works that will cost 30,000. Say, hii pesa yote labda wanataka tu kukula pesa. We have heard all that. And that is because of the competitive environment we are in, that sometimes looks at health as almost a commodity for sale. So why should we bother about compassion and trust? Illness is very inconvenient. It's very unpleasant. It's just an inconvenience. You are told so-and-so is sick. Within an hour, you'll be in a WhatsApp group fundraising. It's a really both to the patient and to everybody around them. But also major illnesses like cancer. We work with cancer patients all day, every day. They cause such disruptions, whether it's cancer or non-communicable diseases, a major chronic illness. They cause such disruption, intense emotions, insecurity, anxieties, and difficulties in making making decisions. And that's why such a consumer of healthcare needs to be approached from a point of compassion and trust in a system that they trust. Because if they are diabetic, they will need to consume healthcare services the rest of their lives. So they had better be consuming that from a system they can trust, and where they feel well looked after. Otherwise, they'll just go to some mganga from some place. But even as we have major scientific and technological advances, the human elements of compassion and trust, respect for patients' autonomy, these ones should remain a constant. They should be. We may bring big machines, PET scans, and God knows what else, big molecular labs, but for the patient, how will I be treated when I get there? And there's a lot of literature that reports beneficial health behaviors from patients, less symptoms, improved quality of life, and satisfaction with treatment when they trust their healthcare professional. If they trust their healthcare professional, they are going to take their insulin as instructed. They know these guys mean well for them. Yeah. So how do we foster trust and compassion? I was hoping this guy is not coming to chase me from the podium. I need to say one or two things of how we foster trust and compassion. Maybe it's time to start thinking about co-creating solutions with the patients. Co-creating solutions to the challenges that we face, and work that alongside with the patients of how can we do this, what we are doing better, how can we improve our processes, our patients' flow, but they can be part of co-creating those solutions. So they don't show up to a clinic, wanaambiwa hii njia imefungwa, leo mnapita huko nyuma. They may have good ideas of how best some of those things can be done. And I think as the healthcare providers, as part of the system, we need to cultivate greater transparency and accountability. A time to get really accountable and transparent to our consumers. But also important is collaborative decision making, because patients are really not spectators in the healthcare system. Are they spectators? They should be part of providing solutions. So let's engage more. And for community-led engagements, very often we sit in our settings and decide we are going to do a medical camp in some place or some screening in some place. Maybe we need to empower our communities to be the ones to come up with that, to say, mutulete camp. But often it's the other way around. We sit, plan, and show up with a van and tents and do what we have to do. But if we are going to foster trust and compassion, we may want to also make sure that the community is well engaged, maybe through the community health promoters that are in every county. But the digital solutions are also important for patients to access information and care. These digital solutions may well save a patient a trip to the hospital, because maybe they can text somebody, they can call somebody, or they can check on WhatsApp. And where you have patients groups with WhatsApp, Like we run several WhatsApp groups, and patients sometimes ask simple questions on the WhatsApp group that are responded very accurately. And that saves them a trip to a hospital or a trip someplace. So these are technologies that we can embrace, especially where you have a homogeneous kind of patients. Then you could put them in a WhatsApp admin controlled where information is shared and accurately. But our healthcare system, of course, needs to be more dynamic, to be more supportive and more inclusive. Almost lastly, a compassionate care needs to be part of the organization's norm. It should not be a norm for one department. It should not be a norm for patients affairs unit, Dr. Iroda. It should be a norm across the institution. And for us to do this, leadership is critical. The leadership must display, those traits of compassion and trust so that they can trickle down. Have organizations that are able to actively support, develop, and recognize the role of compassion in day-to-day practice. And therefore, we as leaders, because everyone is a leader at some level, we must look at we should abandon our individualistic or heroic models of leadership. Like, I'm the leader, I'm the guy, I said, this got to be here, this got to be done this way. Those things are not compatible with compassion. We need to look at embracing shared and distributive adaptive leadership and do away with stifling regulations, being so rigid and coercive, especially as we work with an increasingly younger workforce, Gen Z. We need to let them have a lot more control, a lot more say. And obviously, because we must have controls and balances, they should have a human touch. The other ways of fostering compassion include employing non-pharmaceutical interventions, counseling, good communication, safe spaces, anything that makes a patient know that we are sensitive. If you go to CTC over here, sometimes you get some good music playing in the background. Those are all parts of just fostering a culture of compassion to help patients cope with the effects of treatment or side effects or with their fears. I'm told I have about 15, 20 minutes, but I'll donate those to the next speaker. Yeah. So in conclusion, if we are going to transform our healthcare systems to be resilient, patient-centered, and community-driven entities, we must make deliberate efforts. We should not just tell people, our staff, our teams, and those we work with, we should not just tell them to be kind. We may not have had enough time to look at even various tools that measure compassion and programs that have been tried to help foster organization-wide compassionate programs to make people more sensitive, more empathetic to the needs of the patients. So this has to be intentional. We must include this within our policies, within our everyday practice. And leadership is critical. This is the one that has to start from top down, not just bottoms up. It has to start from up there to have leaders. They perceive the leadership is compassionate, is trusting, can be believed. A lot of those things just trickle down much more easier. But struggling to be compassionate from bottom and the leadership is not with us, then that doesn't work very well. So it's important that this becomes a culture, not just for people in palliative care. They are the ones who should do compassionate, nice, loving care things. This should be a culture, even in accident and emergency, even when dealing with all these stressful situations. Patients can just read that this person is they can just read it through, that one is either angry or needs compassion themselves. So with those few remarks, I would like to ask for one clap and I can sit down.
Thank you. Thank you very much, Mr. Makumi. I'm sure we can give him a better clap than that. Thank you. Thank you. And we remember Mary, competence and compassion. Thank you very much. We will not take any questions for this session. We'd like to invite the first panel. Mr. Martin Munene, karibu sana. Okay, Mr. Martin Munene is our moderator for this session. Would you like to invite your panel?
Good morning. Good morning again. So my name is Martin Nene, and as it was mentioned, we're going to have our first session with the panelists. So I'd like to call on stage about people who are going to discuss with us. So I'd like to invite Professor Chokwe come on stage. I'd like to invite Dr. Mary Maina, Ms. Benta Omonge, Ms. Christabel Wesonga, and Mr. Murioki Marete. Let's put our hands together as we welcome them to the stage. So thank you so much for honoring the invitation to come and share with us a part of the experience and expertise that you have. And I would like them to give them each a chance to introduce themselves to us and tell us what they do before we can go into the panel session. Thank you. He proposed this ladies first.
That was a clever way. Well, good morning. Morning, colleagues. It's a pleasure to be here. I want to thank the KNH Patient Affairs Department really for putting this together. I think the opportunity was just to introduce myself. I'm Christabel Wesonga. I am a nursing director at the Aga Khan University Hospital, Nairobi. I look after maternal and child health, which is very close to my heart. I also look after the accident and emergency and all the ambulatory centers. Thank you.
Welcome.
Morning, everyone. Name is Dr. Mary Maina. I am an obstetrician gynecologist. I work at the Kiambu Level 5 Hospital. I am the HOD, and I am also the chair of the County Maternal Perinatal Disease Surveillance and Response, and I am glad to be here. Thank you for the invite.
Thank you.
Good morning, everyone. My name is Benta Omonge. I need to make a bit of a correction on our program. I was Director Nursing Services. Now I am Outpatient Services Coordinator. We run 6 outpatient centers across Nairobi County and Kiambu County. I need to find you. And besides that, my biggest love for what I do is that now I am a certified patient experience program professional. And so my joy at being invited for this meeting was that we finally have an opportunity to share what patient experience really is about. And I hope that we can have that discussion this morning. Thank you for the invitation. Thank you, Kenyatta.
Thank you.
Good morning. My name is Joseph Muriuki Marete. I'm a registered nurse and also a counseling psychologist. I work at Kenya National Hospital. Currently, I'm working with the HIV care patients at the CCC. And I'm so glad to be part of this great team that is discussing patient-centered care and the family model, which I think is going to revolutionize patient care in this country. Thank you so much.
Thank you.
Good morning.
Good morning.
And there's a reason I asked them to introduce themselves first so that I know what I came to do. We are the invisible people in medical practice, and I think that's part of the reason we were invited. We pulled out of our little holes where we do our things, even though you probably see us in the corridors and interact with us in critical areas without actually knowing who we are. My name is Chokwe Thomas. I teach anesthesia at the University of Nairobi and also handle critical care. And with Kenyatta National Hospital over the last 25 plus years, we have run multiple academic and educational programs, support systems within the ICUs and the theaters and the critical care units that we have established so far. And we worked with most of you in many different areas. In fact, when you see the names of the programs, you think of a different person and you see them all growing up. It's been 20 years, right? So now he's holding the microphone and introducing people. When he walked into ICU first, he was shattered by the equipment that he was handling with the patients. Thank you.
Thank you. Let's give them a clap again. So as we engage, you've had their different backgrounds. We are coming from a point where healthcare system has learned to give us the answers into a place where we engage. We are coming from where a patient would only listen to what the doctor says and not, be heard. But times have changed, and that's why we are saying that we want to make it as interactive when we are engaging between the patient and the care provider. And so as we start our discussion today, I would like to ask Madam Wesonga, as we think about having a meaningful engagement, would like you first to tell us what it means to you to have a meaningful engagement. And then you also let us know if there are challenges that we have to ensure that the patient and the care provider interaction is meaningful.
Yeah, thank you. Meaningful engagement. I think our first speaker really did bring to light what patient-centered kind of care is. And maybe I would take it further, I would push it a little further and say person-centered, because remove the patient out of the picture. You're first a person before you become a patient. So really, what would that meaningful engagement be? It looks like having respect and dignity. Treating everybody with respect and dignity. Look at that person from their perspective. How would they want this care to be delivered to them? What are their fears? What information are they looking for? What involvement do they want their families? Is it, I want you to go to theater, maybe like Doc would say, I want us to go to theater here and now. The person is anxious. Can we give them time to communicate with their family, their friends, to get the risks, the benefits? Yes, you have told them what there is, but what are my cultural beliefs? Can I be given time to discuss that before then I can make an informed decision? So that's what I would think a meaningful engagement is. Be given time to interact with all the aspects around. And yes, are there challenges? Yes, there are. I think we have already had, and healthcare can never have enough of healthcare workers. That's always the biggest shortage that we do have. So I think one of the biggest challenges is really the labor and the workforce. We don't have enough to spend the time I would want. If a client or a person needs 30 minutes from me to have a conversation around their disease, am I concerned about the queue? If, for example, from my nursing perspective, my nurse has a number of clients they're looking after, but there's this one client who has so much time, they need time to discuss their issues. What can I do? So I think workload, sometimes very complex disease processes that we are unable to actually handle, and it would require multiple teams. Do we have enough time to organize frequent family conferences? Because those are some of the ways then we get to engage more clients and get to work together. So I think that's what I would put forth.
Thank you very much. Professor Chokwe, I'm sure you were listening keenly, so I come back to you. You've said that you interact with most of us, but in those hidden points, and probably from your point of action, you're always wearing a mask when you're dealing with a patient or a client, probably before you anesthetize them, you put them to sleep. And if not so, you're standing before students and you want to share them part of what you have learned over the years and part of what you want to share with them to be as good as you are. So, and I guess you have interacted with both patients and students at different healthcare settings. We have private institutions, we have public institutions. So how would you rate the challenges that you have encountered in the course of time in these two setups, maybe the public, the private, and also dealing with both old, middle age, and young in terms of having a meaningful engagement?
You wanted a lecture.
Make it as brief.
What mask are you describing? The mask of COVID, which everybody wore, or the mask of confidence that we walk and pretend with? The mask of worry, which a patient definitely interprets on your face when they see you? You have to translate your medical space into what you see the patient in front of you is presenting with, the environment that is able to support that, and the people who are asking you for this particular help. It is not different in the private sector from the public sector. It's a community that determines what you do and how you treat those people. If you wear a different cap because you're across the road in a higher setup than what you do when you're in a general public setup, you're making the first mistake. Because you stop treating that individual, you stop actually finding out the diagnosis, you start pretending. And in the process, you can actually hurt those individuals. And this is very important, especially so when it comes to handling healthcare workers, because those are the biggest problem. They have all the knowledge and they want to give you the diagnosis and the treatment, but they can't inject themselves. They want you to take the responsibility. You must treat all patients across the board with the same level of dignity. Then they understand and respect you. Old, younger, knowledgeable, or otherwise, get to them at their level of understanding. Try and ask them what they understand the problem is, what solution they're seeking. Most of the times, the basics of medicine is in the sense that pain, for example, is the greatest motivator that will bring them to you. And secondly, the fact that they cannot function to what they want to do every day. So that's what they want to get back. So they're trying to understand, what is this thing in my chest that is not making me able to go to work every morning? Why can't I keep the food down my stomach? Why am I not able to move my leg? Explain it to them. Give them the options of therapy. If they're students, make them understand how all these things integrate together to give you a solution to make sure that this person gets healed. And sometimes it's not healing, but make them understand that whatever they're suffering from might not have a solution at that particular point in time, and what options you can give. Comfort at the end of the day is what. Thank you.
Thank you very much. Dr. Maina, as you serve clients at a county level, I suppose you have also interacted with other healthcare settings at different levels. From your perspective, what are some of the institutional or systemic barriers that would probably come our way and stop us from having a meaningful conversation with a client or a patient, or even the patient's relatives in the course of our interactions?
Okay, thank you. I think all the challenges of healthcare are found in the counties. So for those of you who are in Kenyatta and in fancy facilities in Nairobi and its environs, you may not identify with our challenges. However, When you come down to the counties, you find a healthcare system that is more interested in beautiful buildings, for example. All right. So you walk into a beautiful building, but when you walk in, you do not find anybody to even show you is not given priority. Governors and healthcare leaders want to put up 10-story buildings for healthcare facilities, but not bring that patient experience and personal experience, not give it as, not make it a priority. Then we have very restrictive rules. You didn't have diapers, you want your husband to bring the diapers, but they tell you no, the visiting hours are at 1 p.m. And for me, that's something I'm taking up with the county as a personal experience, where I think, especially in maternities, because that's where I work, we need to let go of these very restrictive laws and regulations that we find in the facility. Number 3 is that we are not very interested in motivating our staff. And at the end of the day, a patient's experience really depends a lot on how motivated the staff is. So we really don't care about the person giving the care. We are very interested in how many patients did you see, but we are not interested in the quality that that person received. We are more interested in the quantity that the person received. Thank you.
Thank you very much. Madam Omonge, well, quite a number of us are staff at KNH. Oftentimes we refer Nairobi Hospital as across the road. You can bear me witness. He talked about across the road. And maybe it could also mean Mater Hospital, Aga Khan, and any other facility. But from Kenyatta, then the next hospital you probably think of across the road. We are looking at some of these barriers that have been mentioned, maybe at a county level, maybe even at our national hospital level. What do you think we would do to overcome these barriers so that then whenever a patient comes to you, whenever a client comes to you, you have a meaningful engagement? You don't look at that person as a case. I'm sure you've gone into a place where somebody is doing a case presentation and throughout the patient is referred to a case. And so how would we break the barriers to have a meaningful conversation? Whenever the patient comes, they can trust the information they are going to share, that you will utilize it, to bring up the care. So how would we get over those barriers?
Okay, thank you. That's pretty loaded, but let's see if we can break it down. And I'm going to borrow from what the others have already talked about. But really, to be able to give the patients, whether they are in Kenyatta or at the Nairobi Hospital or across, as we call it, to be able to give them a unique experience really sits at the heart of what as healthcare workers we must be able to do. And so experience must be experience of any person seeking healthcare in whichever facility. But that would come from a workforce that appreciates what experience really means. And so based on what we have already discussed here, it's important that as healthcare workers, whether here or across, that we understand, first of all, that what we have is what we will give, which then would make one think, so how do I get the staff of whichever hospital to feel that they have something to give? One then looks above that and says, the organizations, the managers, the governance structures must first of all appreciate the workforce. You must give me, as a nurse on the ground, the feeling that you appreciate me, that you care about me, that you know that when I come every day, I'll be able to deliver that care. And I can only give it if I also feel like I've been appreciated. So it's important that our healthcare workforce knows that they are appreciated for the work they do, which would be one. And so looking after staff engagement becomes very important. Once your staff is comfortable in their space, once your staff knows that they come up every day to look after patients, how they show up on a daily basis becomes important, because then they come knowing that today I have come to meet with people who need my help, who need my presence, who need me to be able to speak to them, to speak to their needs, to speak to their problems. And so they are able to give the love that they have received, or the compassion they have received, the trust they have for the organization. They can then be able to share it across to the patients, because patients will come to hospital. Technically, we are all very well resourced. We know how to do injections, we know how to do anesthesia, and it is a given that if I come to the hospital, this is what I'm coming to get. What we are not able to say to the patient is whether they will get the experience they are seeking when they come into the hospital. And that's the extra bit of compassion from Mr. Mukumi, trust that we were talking about, that the patient hopes that they'll be able to get from the workforce. So first treat your workforce well, and then anticipate that they'll be able to translate that to the patient. And for you then to be able to have a meaningful engagement with your patient, you will be working towards a patient-centered approach to care. You will need to be able to empower your patient, empower them in the sense that they are now co-decision makers with you. They are able to put in information about how they feel, how they want you to treat them, how they want you to work with them, whether or not they have a say in the treatment you're giving them. They want you to listen to their opinions. Really, they're voicing their fears. And based on your information, because you're the expert here, if you give them back education in terms of the things that they're talking to you about, then they're able to make a decision. Then you must live with it. They must know that if we do this, this is what's likely to happen. If we do not do this, this is what is likely to happen to you. So based on that information, they're able to make a decision. But for me, what I think is still lacking is the fact that even when we have shared that information, I don't know whether we are getting feedback, not from the patient only, but from their family and from the communities that we serve. And so for hospitals, I think that it would be very, very important to have, I would call them committees, that have all these people across that are then able to give us feedback so that we can improve on the service that we give them, on the care that we give them, on the compassion that they're looking for. So I think.
Thank you very much. Thank you very much. So I hope we are picking these important words like co-decision makers, so that at the end of the day, it's not the clinician making all the decisions, but you're involving the patients. Now, Joseph, it was mentioned earlier that patients will come to us either because they have pain or they have some dysfunction. And so they are coming to seek for care from you as a healthcare provider. But sometimes we could be coming from a point where we lack culture, that we forget about patients' background. We lack empathy. Sometimes we lack respect. And I'm sure you have seen a patient where, a situation where a patient has been disrespected. Patients lack trust in us as care providers. So how is it possible for us as healthcare professionals? How is it possible to put in place, to cultivate empathy, to cultivate respect, and, to provide a situation where the patients will trust whatever information they are sharing with us? How would we cultivate that?
Thank you, Martin. As we are sitting here this morning, I'm trying to imagine who is this person that you are calling a patient. And I'm imagining that you're talking about services that we ourselves consume as participants who are in this room, and even them that are in virtual. And the healthcare professionals and other healthcare systems, we are judged by the past experiences of what patients go through when they come to us the last time they were with us. And I'm looking at that patient who is in the house, and maybe he or she has a clinic appointment and supposed to come to the hospital, and she wakes up at 5 or 4 in the morning and develops all anxieties of getting to that facility and meeting the same people she met or he met the last time he was in the hospital. And people who are involved here in doing triage in the hospital will agree with me that there are very many patients who come, and as you record their blood pressures, they are quite high. I know there's a name that is given to that. And not only those patients, it is you. Some of you, and some of us here, you fear even to attend clinic appointment in even your own facility because of what you went through, the experiences that you got. Maybe when you are told you are going to be admitted, you don't want that because of the past experience, most probably which was not present. And therefore, even as we are thinking about what can we do, empathy and trust, I think it's something that we need to work it with ourselves. And a number of things have been mentioned in this forum by the panelists here, that we are not talking about that person out there. We are talking about a person who has come to us in need. And this reminds me of a drug that used to be used a long time ago. I don't know whether you remember it. Some older people, there's a drug that used to be called Suta. I don't know whether you have ever figured out what that drug was. Maybe the pharmacists here will tell us because they are in this forum. But it used to be a wonder drug that patients knew when they go to that kiosk and they're given Suta, their problems are sorted. And I'm imagining that we will need to develop a healthcare system that patients, when somebody is in pain, like my colleagues are saying, will say, if I go to KNH or if I go to Bagadi, my problems are sorted out. But as has begun, I said, most of these patients will have a lot of anxiety, even before they come to the facility, because as Dr. Maina was saying, they are not sure whether when they come to the gate, the security officer there will allow them to be seen. Two, the information that they receive, even when they come to us. May I begin by talking about when they come to us, navigating our complex care systems alone puts them off, because you get to the records, you get the clinician, and then you are sent to the lab. The lab is maybe in another corner in the hospital, or it is not even there. You are supposed to go and take your sample in another facility outside there. And this puts a great toll on the kind of clients or patients that you're taking care of. But you ask me, what are we going to do? One, as their healthcare professionals, we need to ask ourselves, what is it that I would have wanted to be done to me if I was in that seat as that patient? I'll say one, every client will want to be listened to. And you'll agree with me that many times we talk to patients and we do very little listening. Reason being what Mr. Macomb talked about, the workloads. The workloads in the healthcare setups, and you are not seeing the patient who is inside your room, but you're seeing the ones who are outside there, and the queue that you want to clear. When it comes to the nurses, they are not just looking at this patient who is hypertensive and has diabetes and maybe they need to take a blood pressure and the sugar, but thinking of the 40 patients that I have to attend to before I knock off in the afternoon. And that makes the clients not to feel our impact or their experiences with us is they are here just to do their work and go home. But when we listen to clients, we'll be able to listen even to what they never said when they got admitted, or even what they didn't even tell the first person they came into contact with. And another thing I would say is we need to involve them in decision making. We need to really involve our clients, and I'm talking about the patients and their family members. When a mother brings a child to you, don't imagine you know everything because you did pediatrics as a training. It requires you to involve that mother because that mother knows that child more than you, who has been with the patient for only 5 minutes. Another thing I'll say, and it was said by one of my colleagues here, is it quantity of time or quality time? It is possible for you to spend 50 minutes, but it become quality time. You know, we are doing a lot of I think they're called questionnaires. We do a lot of trying to find out what the patients feel, and we also do the turnaround time. And we are checking this client who came in. It took 15 minutes. Another one took 30 minutes, and another one took 3 minutes. It is possible that it took 5 minutes, but to come out agonizing, and you don't want to come back to that person again. And you took maybe with somebody 2 minutes, and that's really changed the way your experience about the hospital, the experience about your, even your own disease. You have been able to understand many things. And so when it comes to involving family, involving the patient, that is key and very important. Maybe the last thing I want to mention, Martin, is you have talked about empathy. We need to do empathy skills training to our healthcare workers. It is something that needs to be urgently done so that we can help ourselves to know how do we put ourselves in the shoes of this client without necessarily getting immersed, without necessarily, being the sick person, or without also becoming sick, but the same being able to address the cares and the worries of this client, even as we try to figure out their diagnosis. And so some of these trainings will involve how do they break bad news, counseling for maybe the chronic illnesses, issues of loss of organ, and many other things. We need to do a lot of training on empathy, so that we can be able, our other professionals can be able to handle the patients that come into contact with us at the healthcare professionals. Thank you so much.
Thank you very much. Thank you for giving us quite some details. Now, we've already had that part of the things that need to be done. One was mentioned as staff welfare. We need to take care of the staff. But sometimes we have structures that need to be put in place by an institution. And I think this would probably be an example. Madam Wesonga, would you think of other things that would be done to be able to promote transformation, so that we are looking at the things that used to be done? The client that we are dealing today is quite informed. So we also need, as healthcare system, need to be transformed to be able to fit in what is happening. So what is this in a healthcare system that would be done for us to transform, where we would say, previously we would treat patients as a patient or a case, but now we want to incorporate them in our system? What are some of the things that would be done at an organizational level?
Thank you, Martin. I think before we get to organization level, the generation we do have is, and we are churning out very many doctors, very many nurses, very many, all the medical team. And in our training, maybe we need to get there. I think one of the places we need to improve most is our training. We do have a lot of technical skills, and no doubt, globally it's known Kenyan medics are very good. However, what are our other skills like? Our social skills. And so I think as we review curriculums, we need to incorporate communication. We need to incorporate counseling skills. These are some of the things that now the regulators need to look at much more. And I can say, for instance, right now, the undergraduate program that the Aga Khan started recently, they actually have incorporated the communication skills. And that really helps you engage, communicate with each other, discuss, see how you'd counsel a patient, how you would do your listening skills. And that is also assessed so that as we are starting from the background, we already have those skills being inculcated into us. We know how to approach each other. We know how to approach the team. We've also talked about patient engagement. I know there are many strategies that very many organizations are looking at, that you do have people like patient experience managers, which Madam Omonge is telling us, those are people that are walking around and trying to just engage the clients that we do have, picking them up and probably being able to understand what they would do. So focuses for those may be that we have not trained. We need to bring it up in the training. And then organizations, those of us who have already been trained and are already out here, we need to be engaged in more of these seminars. What KNH is doing is really a good thing, opening them up, making them online. And we also do have short courses that we can get to do. I think the human resource team need to be very greatly involved in this, because she did mention a very strong point, staff engagement. When staff, bring up their issues, how are we handling them? How are we managing them? True, you cannot give what you don't have, but can we also be trained to be self-motivated so that it will not depend on whether I come to maybe my community hospital or my public hospital. Maybe I live across Mbagathi, and sometimes you see like the place is so busy. There's this client who is barely able to walk. So you're looking at it and thinking, can't somebody come up and approach this client? Right from the security team we employ or engage within our facilities. So I think that is where we need our HR team to come, give us some of the activities that can take us out of our comfort zone. Can that security guard engage with a physician, for example? Can they interact? Or when they see the physician driving, they will salute the physician, but the patient that the physician is going to see is actually being locked out. So those are some of the things that we need, and probably things like team building activities, bringing them on board, because they are really the gatekeepers of healthcare institutions, would help. The housekeeping team within the institutions, are there lesser people? No. Without a clean facility, even you as the healthcare worker will not be able to work or deliver care. So I think we need to make one big team and not just focus on this one area, which is the clinical care providers. Once we do that, all of us will have respect. We will have that person who is lying in that bed treated with dignity, the person who is coming to the clinic respected as well, treated with dignity. And that way, I think we will improve our care across, and I think our experience for clients will be improved. Thank you.
Thank you very much. Mrs. Omonge, we have had quite a bit of details. We need to have a system that does not just look at the patient as a patient or a case, but you need to have an engagement of a system so that the patient coming in through the gates is probably also given a salute. And the patient, oftentimes, they do not come alone. We are talking about patient and family-centered care, where you want to involve the family. So how best then can we incorporate family in everyday care of our patients? Because oftentimes the patient is lying on the bed alone. And for those who have been patients, I mean, the ceiling is often is what you watch most of the time. So when the doctor, the nurse comes, when whoever therapist come, the patient is staring up. So we do not have the relatives by the bedside, but along the way, we need to incorporate the relatives so that it's a family-centered care. So how best then would we, if we haven't initiated, how best would we do to bring in the family? Where can we start to bring in the family?
Wow. Let me just go backtrack a little bit and just borrow from what we have heard in terms of staff engagement. Staff are human beings, right? And they're looking after patients who are also human beings. So it's really human beings looking after human beings, right? When we understand that bit, then one wants to appreciate the experience he's talking about and state that as I prepare to come to a facility for care, my worries begin at home. My worries begin at home. What will my experience be? Will it be like it was the last time? And so you dread coming into a place. So the patients that come to us begin their hospital experience right from their houses. Right from their houses. So we need to have a platform that enables them to engage positively with the hospitals before they leave to come to our hospitals. For those hospitals that have the ability to book appointments from home, yes, engaging or having say a digital platform, because we now have very young, very technically savvy, even parents, young adults, having platforms that they can engage with from home, and everybody is carrying a smartphone. They can be able to engage with their doctor, with their hospital from home before they come. Making it easy for them to come into the hospital initiates their experience for coming to the hospital. But then one would want them to understand how we define the experience of a patient. So what is really this experience we're talking about? A lot of definition goes around, but what stands is that the patient's experience when they come into the hospital is the sum total of all of the interactions that they will have when they come into the hospital at every touch point. These interactions are usually influenced by the culture within the organization, and you talked about culture at some point. That culture, when the patient is coming around, that's what the patient is seeing the staff to be behaving like, the culture within that organization, that influences their perception of how these people are. And so how the patient sees the staff behaving, the culture within that organization really influences what they will feel as the experience that they have had in that hospital. And then later on when they leave, the fact that I call you to ask you, did you settle well after you left the hospital, after discharge? And I'm calling you not today, not tomorrow, 72 hours later, a week later, I still want to know how you're doing. It's still a part of the experience that I have had with your organization. So making sure that that continuum of care is such that the patient is left with a memorable experience becomes very important for your hospital, because the next time they want to come for treatment, they'll think about the experience and directly come to your institution, whichever one it is. But you cannot work with the patient in isolation. There will be the very next of kin. For the child, it will be the parent. For the married people, their spouse or their significant other, their partner, someone must actually be available with the patient. So the decisions that the patient takes, that family conference she talks about, must involve both the patient and the very important persons. And the patient must be allowed to select who will be present in my conference. And I think Professor Joffe would bear me witness that you would have to ask the patient, who would you like to be, if they're able to speak? Who else do you want to hear this conversation? Many times you'll find spouses or children who do not want to take responsibility, especially if it's a hard one, a difficult patient, a critical patient. They want the brother, the sister, the relevant auntie to be present in this conversation, so that when a decision is made, no one feels as if they are to blame should the patient not do well. A shared decision is always one that is always better, because then the patient feels engaged, the family feels engaged, they have the flexibility of calling their consultant, their doctor. And we no longer can say, we must stop labeling some people on our phone as ignore, because this relative calls me too many times. So when I see the phone ringing and I see it is one of those I labeled ignore, I don't pick. Because it could be the call that is the differentiator for that patient, right? So we have got to be able to have that relationship. It's a relationship we're creating with the patient. It's not a doctor-family that kind of relationship. So we must be able to engage them at that level. It may be tedious for those who have lots of patients, like Professor here or Daktari here, but we must find a balance between how you speak to me. And many times, if you sit with the patient and the family and give them the details as they are, the truth about your disease is that this is where we're at now. This is what we are going to do. This is what is likely to happen. Chances are that their calls to your number will also reduce because they now understand what is going on with their lives. Lastly, visiting hours. And the Askari who tells you you can't come in because it is not visiting hours. We must remove that kind of a restriction about who you engage in your care. So maternity and husbands and dads, they really should have a free visitation because they are bonding, they're helping their wife, the wife is overwhelmed. So if you can, as much as possible, allowing family to come into the place actually reduces the number of times they come. Yeah, because they know they can come in anytime. You will probably be able to control visitors better that way, and that is possible. I've seen it in other hospitals.
Thank you very much. In the 18 years or so, Professor Chokwe, when I first came to Kenyatta as a novice ICU nurse, I really didn't know much. I was coming from a dispensary. I had not interacted with such systems. But in the years, I have known you as a lecturer at the University of Nairobi. I suppose in the course of time, you have interacted with many others whom you have mentored into this career. So in the course of your time, does the curriculum help us to build these soft skills so that then we are not just being competent, we are not just releasing competent graduates, but we are also releasing compassionate graduates who are able to show some empathy. Does the curriculum accommodate that?
I'll give you one huge secret that might never have been spoken. You're asking about people with competencies and everything else. But the people in anesthesia, I'm not seeing them here today, but they will tell you the hardest question at the anesthesia interview is a very basic question. Why do you want to do anesthesia? And half the people get lost with that particular question because they get confused. Why are you asking me this? You should be asking me, how do you treat certain diseases? How do you handle critical care patients and the likes? The next very difficult question is usually asked to our fellow specialists when they're talking about the doctors that we have been training. And they're asking us, why aren't you releasing Dr. Kariuki? We think he has finished. And the question we ask them is, will you allow Dr. Kariuki to treat you or your children? The mask you wear, the expression you give me is an answer to whether you'll allow Kariuki to treat you or your patients. So the translation of soft skills, the translation of compassion is an evolving thing. It is not something that can be structured into the curriculum with the kind of timing we have. We have a generic curriculum by the Medical Council for all courses that are passed there. But as we train our individuals, as we interact with different communities and populations, then we improve on the content of what we teach over the time that we are with the students. The curriculum is only a framework. The people who deliver this curriculum, translate it to the students and help with implementation, then look for the resources to incorporate some of these things. There are a few of my students in the audience, and some of them said they came because they saw somebody's name in the program. What are they following? What they saw you teach, what they saw you practice, what they've heard about you walking in the streets and the likes. And when you see them follow you, it tells you there's something else they're looking for. What knowledge did you give them? Our anesthesia undergraduate exposure, for example, is 2 weeks. The maximum in this country is 4 weeks. When they come initially, they think they come for a holiday. By the time they leave, they want to stay longer because they've not had enough. We don't have the capacity to accommodate that, but they understand what they require to do. So that translation is integrated continuously. So it is not something limited. And many patients, many nurses, and your students keep on watching what you do, how you interact with those patients and everything else. If you're what is described as a bad doctor with good outcomes, that bad behavior of the senior consultant is what they will pick up because they think that's what you're meant to do. They also pick the science and the other things that come into play in their lives. I'd also want to answer some things that you've been discussing with them. And I'm glad I've seen people fitting into the back of this particular auditorium, the security people. 20 or so years ago, Dr. Misheni was the CEO of this hospital, and we used to sit in meetings trying to understand patient care and everything else. This is not something that started today or what you're starting with here. And that time we were discussing how to manage patient flow and casualty, better patient experience, and translation of what Kenyatta stands for. And one of the questions I asked was, what information does the security man at the front of the hospital have as far as this institution is concerned? Is everybody who's coming through the gate a suspect? Because that is the basic security training. Those of us who went through NYS and everything else, is everybody in society is a suspect? Do we have an onboarding program for them when they join us? We have a lot of people who are now outsourced. Your cleaners who are outsourced, your security people are outsourced, your caterers who are outsourced. Do they understand who they are dealing with? When they see you walking into the hospital, they just don't think it's a consultant or whatever. But if I come in at midnight and you say, this door is closed, use the other door. The midnight hour for me to be lazing around Kenyatta National Hospital must have a different level of translation. So there's a level of education that you must give them to empower them make those decisions, because their basic training, knowledge, and integration of what we are doing here is very standard. Stop everybody else from coming. And some of them are not in security because that is the job they're trained in. It is the job they could find. And if you talk to them, you'll be surprised as to what kind of things they can do. They're electricians, they're accountants, and quite a number of people from security in this hospital are now working in different units of the hospital because we identified them, we gave them access to further training, and they participated in those things. And they can help us in patient care. Simple moving of patients. A patient who is in pain is coming with crutches. They cannot find their way to the orthopedic clinic, where to find wheelchairs, where to find patient trolleys, are things they can facilitate. And we must enable them to do that. Thirdly, I think we're talking about visiting hours and cultures and the likes. You must also travel the world and see what people do. Africans want to stay around their people. Educated Africans want to pretend they love their people. Okay. The Asians will live with their patients in the hospital. If you go to the Asian hospitals, you will actually find rooms in which the patients stay with their relatives as a standard. Okay? There are other people within the African space will come and ask you, why are you taking so much time with our patient? If they're not getting better, let us have this patient and we go away with them. And if you don't allow them to go with their patient, they will do something to that patient and let them go. The Europeans, on the other hand, you're in the hospital, it is the hospital's responsibility to take care of you. Call us when you want us to take him home. So cultural integration is very important for us to recognize those things. And we must be able to talk to people and find out. As you said, the patient will say, so-and-so is a person that I trust and I would want you to share information on my care and how to handle it. But there's always somebody else who shows up a minute later who says, you must do everything and we will pay. Yet you're not the ones who pay. So you must also be able to identify this.
Thank you very much. I think the last question I want to ask Dr. Maina, you interact with enough patients in the course of your care. And we've always had this slogan, wacha kuuliza maswali kama ya clinic. Have we heard of that slogan? You know, you're asking so many questions. So, and especially in obstetric and gynae, we have this list of set of questions. So how then, with the information that this patient has, how then are we able to integrate what they have to the care that we are giving them so that we are going to be core decision makers in terms of their care? How would we incorporate what they know and what we know as professionals so that then the final decision is not the doctor's decision, but our decision to see the well-being of the patient?
Okay, thank you. I think for those of us in obstetrics, you appreciate that those maswali ya clinic are also very intimate. And sometimes you ask and you'll ask a patient questions and they'll wonder, what are you trying to get to? But as we said, patient-centered care means we are trying to move away from where the care provider asks those many questions, but instead gives the patient time to express themselves. Yeah. So, and one of the surest way to do that is to stop interrupting the patient, because most of us, as you said, we are seeing the patient outside the room and not the one inside the room. We need to clear the queue. So we need to allow the patient time to express themselves. You need to set an environment that doesn't even start with the medical issues. You know, find out how was your trip here? What did you have for breakfast? Try and set an environment that makes the patient at ease so that they're able to give you as much information without even asking those many questions that we do. And at the end of the day, sometimes the patient will even discover what their problem is before you speak. When you allow them and ask them open-ended questions, as opposed to the many questions in the Masolia clinic that we ask, make your questions open-ended. And then at the end of the day, give the patient the options that are available for their own care. Meaning, I will not tell you if you came with knee pain that this knee must be operated on. I will give you the options that are available and of course within safety for yourself. And then you allow the patient and their family to pick their preference. Yeah. And as somebody said, a lot of other issues, a lot of patient outcome actually happens at home and not in the facility. And that is why we must want to understand beyond the medical issue that brought you here today, what is your setup at home? What is your level of education? I need to come down, as Professor Choko said, I need to come down to that level of education to be able to make you understand what your problem is, what your options are. And then at the end of the day, we will make a decision, a shared decision on the way forward. And remember, we must remember that also it's not just about the curative interventions that we are talking about. We want patients to also take part in preventive lifestyles that will make them not keep falling sick every other time. If you have a diabetic patient who does not know what their HbA1c was 3 months ago, they're unlikely to improve on their diet. Yeah. So we need to have conversations with patients at their level. We need to give the patients options. We need to know what their preferences are and respect them as long as they are within science and safety for the patient. And then at the end of the day, the patient actually takes center stage in their own care.
Thank you very much. So in the interest of time, would like to end our conversation at this point. I don't know if there's just one question that someone has to the panel that is seated here. Maybe you would want some clarification. Any question?
Okay, thank you. Mine is actually a comment, and you guys have said that what is you need to have the patient part of the table and not just like a subject. So I'm a patient advocate, and I do believe all this cannot be done if the patient is not part of that equation. Thank you.
Thank you very much. Thanks for your input.
Thank you for a very interactive session. My question to panelists, or my question to the panelists this morning is, as we are talking about patient engagement, are we considering the ordinary situations like patients who are, for example, LGBTQ community? Because we had an experience in our unit, like a patient asked us if she could bring her vibration to the hospital, and it was a case of concern to everyone, because that was in question. I don't know, was it a cultural issue or a religious issue? Because everybody was like, what a mess. But in terms of patient engagement, trust, empathy, and all this we're discussing today, this is a matter of concern, and we are in the community, like with all our patients are in us.
Let me allow one of the panelists to respond. It sounds like an ethical dilemma that we find. So you want to respond?
Thank you. Not, I think we were with Dr. Maina, and we just discussed and said, yes, I could attempt, but I think I like what Doc said. For as long as it's within science and safety, I think that is what needs to guide all that we do. Always what we say is patient safety. We do have the rights and dignity of the patient, but remember patient safety and science. So in that situation, when we are stuck, and I think Martin has already said it, in my situation, when there is anything, our ethics committee is very, very prompt. It doesn't matter what time of the day it is, they will always get together. We do have a team that is always on call. They will get together, whether virtually or physically, get to have a conversation around the issue that has been brought to them, which we cannot address, and they will always provide guidance. And in consultation with the legal team, they'll always give us a direction on what we need to do in the best interest of that patient, safety, and science. So that's what we do in our situation.
Thank you very much.
You think sometimes the patient is telling you you're not treating their problem, but they're giving you an extra diagnosis and you have not engaged them. I like what has been asked about the patient advocate. It's not because we are ignoring that the patient is the center of everything else that we are discussing today, but this particular forum was for how we deal with the family and everything else. And indeed, the patient is the one who has brought us here. But yes, the ethical dilemmas that come into place, all hospitals have ethics committees, and there's usually a leader, not necessarily the team head within the unit, who has some answers and experiences in dealing with the dynamism that is emerging in today's patient. Autistic patients were thought to be abnormal previously. Until now, we have education to understand what autism is and how to handle it. The so-called Generation Z, or people who are now reading the internet and will come with a phone and tell you my disease, according to Google, requires treatment Z. Why are you seated in front of me? No. Fine, Google has explained to you, you're in pain, you're in front of me. Let's make a shared decision and understand what you're doing. These are the gadgets you want to have around you in the hospital. What exactly do they do? Get into their space. There are patients who want to take supplements. Dr. Ngigi is here, and I want to mention something very important. I have not seen those bottles here right now, but there's a fad, okay? And this is very important and probably a need that we need to send out. Everybody's drinking tons of water because it is the fad that is going on. You're coming to us with problems in ICU because you're drinking too much water and you're losing sodium in your bodies. Yet, it is what is in the newspapers, it is what is on TV, it is what is being sold, and the water bottles are very expensive, isn't it? And you're being asked, you want sparkling mineral or whatever it is, and it's giving us a problem, worse than soda and sugar. So that level of education is what we need to keep on incorporating into the society we live in. Thank you.
Thank you so much. So I think from what the panel has shared with us, there's an aspect of empowerment that needs to go to the patients. There's an aspect of empowerment that needs to go to the caregiver so that we no longer walk in ignorance, but we're able to incorporate our patients as they come. And as long as we are doing it in scientifically and ethically proven ways, we can always consult others. Like he says, we always have another person who probably has an answer. If you can't do it, there will always someone else you can always consult. And with that, we come to the end of our discussion. So I want us to put our hands together, the Nyayo 3 claps to appreciate our panel for their time and for the information that they have shared with us. So let's prepare. 1, 2, 3. I also want to appreciate everyone in the audience, those who are here physically and those who are watching us online, those who are following us online. We also want to appreciate all of you for your commitment. And I want to believe that as we step out of this auditorium today, we are going to have a meaningful engagement with our patients and their caregivers. Thank you very much, and God bless you.
Before you leave the stage, we are truly grateful that you came. Allow us to give you some thank you. And then just to acknowledge that we have our board represented here. You're so much welcome, Dr. Joseph Wafula. And thank you, Dr. Ngigi, for representing the CEO. So we've had the first session. We had Dr. Makumi, the CEO of Haraja Support Trust, who shared with us about fostering trust and compassion in care. And that is to do with cancer care. But it was very, we enjoyed the session, didn't we? Great. And then we've had a great panel here. We've had the University of Nairobi represented by Professor Chokwe. We have Dr. Maina from Kiambu. Dr. Maina, you can wave. And then we have Ms. Benta Omonge from the Nairobi Hospital. Thank you very much. And we have Ms. Christabel Wesonga from the Aga Khan. And also we have our very own from CCC, that is Mr. Muruki Marete. So we're truly grateful that you came. And this has been a very great session, hasn't it? A lot of insight, and across the divide, a patient is a patient, whether they come to Kenyatta, whether they go to Nairobi Hospital, whether they go to Makueni. We are humanizing care. And thank you that you've truly shown us how care can be humanized and the essence of the same, and how we should have it in the training institutions. So thank you. So we'll have Dr. David Makumi to come and get the gift from Charity. Charity works with us at Healthcare Quality. I should be the one to give. Me, I'm the MC. Choose one. Which one do you want to do? Do you want to take this? Then may I give? Yeah. Oh, Dr. Kalundu can MC, yeah? I've been directed by higher sources, so I'll have to do.
Okay, thank you very much, Mr. David Makumi. We appreciate your session in the morning. Asante sana. Thank you. Mr. Martin Monene, please come. Please come. Professor Thomas Chokwe, thank you very much for that insightful session and for your comments. Thank you for making this lively. Thank you for answering to our call. We are yet to learn quite a lot from you, and we are happy to be your former students and continue to be your students. Thank you very much. Mr. Julius Marete, thank you very much for your insightful words of wisdom. Even as you tell us the patient starts their journey from home and they come all the way and still anticipate that. Mrs. Venta Omonge, thank you very much for accepting our response and for your insightful words. And we pick quite a lot from you in terms of modeling behavior, in terms of staff engagement, and what we need to do going forward. Thank you very much. Dr. Mary Maina. Dr. Mary Maina is my former classmate. Yes, thank you very much for answering our call. And we pick the words of wisdom that you shared about where we focus. Do we focus more on constructions and buildings and forget the patient and how we receive them from the beginning? Ms. Christabel Wesonga, thank you very much from Aga Khan Hospital. We appreciate you. We pick quite a lot from you in terms of training, in terms of what we can do to incorporate our curriculum and change our curriculum. And I think there was one for Mr. Martin Monene. Charity, I think you'll come back again. Mr. Martin Monene, oh, Lucy is coming. Mr. Martin Munene, thank you. Thank you for making us not sleep. In the 1 hour that you've taken the mic, I think it's gone so fast. We've not been able to notice the 1 hour flying by. Pastors, asante sana, tunashukuru. I'd like to invite Dr. Dorothy Olwoch. Dr. Dorothy Olwoch is our keynote speaker for this session. She'll be taking us through person-centered care. Dr. Dorothy Olwoch is a health system researcher at Cambry Wellcome Trust. She has over 10 years experience in qualitative research and has a keen interest in maternal, neonatal, and child health care. She's also done quite a bit of work on patient experience. Current project is focused on exploring the potential for using mother experiences, narratives, and digital stories of preterm birth in Kenya. Karibu sana, Dr. Dorothy Olwoch. We appreciate you. To our online audience, we have not forgotten you. We see you, we read your comments, and we hear you. We even see your raised hands. Asanteni sana.
Right. Good morning, everyone, once again. As you've been told, my name is Dorothy Olwoch. I'm from the Cambry Wellcome Trust Research Program. I'll start off by thanking the organizers of this forum for the invitation and for the opportunity to participate in these discussions, which are quite critical as we have discussions about how to improve the quality of care within our country. So as a start, just reiterating some of the things that the previous speakers in the panel have highlighted, is looking at the model of care that is guiding how our healthcare is organized, leans more towards the biomedical lens. So in short, what that means is the focus is more on the disease, and we see people who walk into our hospitals as cases. And the focus is, how do I treat the disease? But more importantly, we are dealing with human beings who are coming from various social backgrounds, issues to do with gender, and different differences in socioeconomic status. And of importance is that these people also come from various backgrounds, and there are things what you call like social support systems or social capital that different individuals have. And all this affects people's beliefs about the causes of illnesses, And if we don't pay attention to these soft issues or social issues affecting care that also determine people's perceptions about what's making them ill, then we will not reach our target of making our patients better. And therefore, it's important to see them as persons with different issues as they come within our hospital setting to seek care. And therefore, it is important to work towards building and strengthening patient-centered care. Right. So in summary, and just as has been discussed in the previous session, patient-centered care is all about providing care that is respectful to the individual, responsive to their individual needs, and also taking into consideration their preferences, values, and ensuring that all these are considered when providing clinical care. And I borrow from this illustration from the Pika Institute, which is well known for their work in driving patient-centered care, and they're based in the UK. So they outline 8 critical domains with regards to patient-centered care, touching on issues to do with access to care, continued transition, improvement of family and friends involved in provision of care. And in essence, as institutions, we need to find ways of ensuring that the care that we provide tries to target these principles outlined in this slide. So there have been values attributed to patient-centered care organizations or organizations that offer patient-centered care. And this relates to the outcome of the treatment that the patients get from our hospitals. So one highlighted in literature, and also what we are seeing in some of the work that we are conducting in Kenya with regards to improving patient-centered care, is that patient-centered care organizations see some of these outcomes. First one, better patient and community experience. And just to give an example is improved patient satisfaction as a patient at an individual level. There are also outcomes that we are seeing that are touching on better workforce experience and improved well-being. And as we know, our healthcare workers are the core of providing care within our hospitals. And it is important to also look into their experiences and also involving them in some of these discussions. But more important, we're also seeing better clinical outcomes, because if a patient is involved in the care, then we are seeing of importance that relates to the issue of cost is reduced readmission rates and reduced length of hospital stay. And therefore, we need to look at patient experiences, because when we look at patient experiences, that's the beginning of working towards patient-centered care approaches. Because when you listen to the experiences, we begin to learn about what is important to the patients and what we need to improve. And this is important in terms of learning what the individual experiences are. And also we begin to think about what's the gap and what do we need to do to address the gaps. It's not just about learning about the bad things with the healthcare system, but also learning about what is working well and what is appreciated by the patients. And in my engagement interactions with the nurses that we work with, they really appreciate also listening to the positives and the things that the patients appreciate about the care that they receive. Looking into patient experiences also help us to challenge some of the assumptions. So as healthcare workers, we might have ideas of what we think that the patients value, but on talking to them, there are little things that might not be so clear to us, but appreciating that from a patient perspective, the little things that we do, for example, a touch on the back, and just seeing them as human beings and empathizing with the situation is quite important to the patients. And through investigating patient experiences through some of the approaches that we mainly use as a research institute, which I'll tell you more in the coming slides. Some of the outputs of the patient experiences work are quite powerful for advocacy and also as a motivator to change. So within the KEMRI Wellcome Trust program, we've been running patient experiences research, but mainly with a focus on newborn units. So what we do is conduct rigorous, detailed, qualitative study that sometimes involve ethnographic approaches. What that means is spending time within the newborn units, observing how care is provided, but also talking to the actors within the newborn units just to understand the context and the culture within which care is provided in the newborn units. And a powerful approach that we use is interviewing the mothers of preterm babies and sort of video recording these narratives, but they're quite open-ended interviews. So basically starting with a very open-ended question and allowing the participant to tell their stories in their words, highlighting things that are of importance to them. So through using this approach of digital narratives, we are able to produce video material that are quite important, as I said, as a resource for public and patient engagement, and also can be used for training of frontline healthcare workers. And I'll tell you in a bit how we are using this material for training of frontline healthcare nurses workers. Key critical to our work is adopting co-design approaches. So we have workshops where we bring together the mothers of the preterm babies. We also bring to this table the providers of the service and just have an open discussions about what happens within our newborn units. And we found this to be quite important in terms of the kind of creating a safe space where the different actors can come together and freely in a safe space voice some of the issues within the newborn unit. And through these co-design workshops, together with the mothers and the nurses, we looked at the material together. So that is the material from the narrative interviews, sort of validated what was emerging from these interviews and had discussions about how can we use this material in our strategies to improve quality of care. And as a program, we've had an ongoing communications and emotional management training. Initially started with a focus of focusing on nurses, but over time we're seeing requests from other cadres of staff expressing interest in this training. So basically, what this training, as was originally designed, did not include any material from the patient narratives or patient voices. So what we've done is, from our qualitative work, brought this material, have discussions with the nurses, had discussions with nurse managers working with the newborn units, and also had discussions with the mothers who've passed through the newborn unit, and just touching on what are the modules covered in this training, and how do we think the material that we have developed in form of videos can strengthen this communications training. And your hospital is one of the hospitals that we've been working with in the newborn unit. And from a research perspective, we are quite happy that we have one of our trainers of trainers sitting in the room and who's championing this course, because sustainability is quite critical to such soft skills in interventions. So well done, and thank you so much for that. So what I'm going to do in the next couple of minutes is just show you a sample of some of the material that I'm talking about in patient. I see a clue that my time is up, but I'll just play it for maybe 2 minutes and then I conclude. But just as a disclaimer that these are experiences of mothers who've had preterm babies and can be quite emotional.
Hata kwenda nursery kufeed watoto tulikuwa tunatoka kwa ward, ilikuwa saa 12, saa 3. saa 9, yani after 3 hours mnaenda. Sasa mimi nilikuwa tunaenda kwanza nachungulia niangalie wako njoo, tulikuwa tunakaa tupanye yani tudogo. Sasa kwanza nilikuwa nasimama tu kumbani nachungulia, nilikuwa na ile wasiwasi. Sasa nikipata tu nikiona kakifanya kwa mkono hivi ama kama mguu, sasa nachangamka naenda. Ilikuwa kitu mpya kwangu. Sikuwa nimewahi ona mtu anatoshana hivyo. Sikuwa natarajia kama naweza zaa mtoto mwenye hapa na 900 grams. Sikuwa natarajia hata. Alafu yenye tu nilifika huko newborn, nikapata tu watoto wadogo zaidi wanazaa kama watoto wako wamekufa. Sasa hiyo ndio ilikuwa imenitia wasiwasi.
Sikuwa najua kama mtoto anaweza zaliwa kabla siku zake zifike. Nilikuwa najua lazima 9 months ifike ndio upate. So hiyo ilikuwa challenge kwa sababu sikuwa na experience na sikuwa na mtu kwamba mtoto anaweza kuja kabla siku zake zifike. Hata clinic hawakuwa na hizo nini.
Juu kwenda nursery kufidi watoto tulikuwa tunatoka kwa ward. Ilikuwa saa 3, saa 12, saa 3 ya saa 9, yani after 3 hours mnaenda. Sasa mimi nilikuwa tunaenda kwanza nachungulia niangalie wako njoo, tulikuwa tunakaa tupanye yani tudogo. Sasa kwanza nilikuwa nasimama tu kumbani nachungulia, nilikuwa na ile wasiwasi. Sasa nikipata tu nikiona kakifanya kwa mkono hivi ama kama mguu, ndio sasa nachangamka naenda. Ilikuwa kitu mpya kwangu. Sikuwa nimewahi ona mtu anatoshana hivyo. Sikuwa natarajia kama naweza zaa mtoto mwenye hapa na 900 grams. Sikuwa natarajia hata. Alafu yenye tu nilifika huko newborn, nikapata tu watoto wadogo zaidi, wengine wanazaa kama watoto wako wamekufa. Sasa hiyo ndio ilikuwa imenitia wasiwasi.
Sikuwa najua kama mtoto anaweza zaliwa kabla siku zake zifike. Nilikuwa najua lazima 9 months ifike ndio upate. So hiyo ilikuwa challenge kwa sababu sikuwa na experience na sikuwa na mtu kunielezea kwamba mtoto anaweza kuja kabla siku zake zifike. Hata clinic hawakuwa na hizo nini. Ndio naangalia tu mtoto anaendeleaje. Niliogopa na nafika hapo napata mtoto ni mdogo, ni sija anatoshana, alikuwa mdogo sana. Sasa hiyo imekuwa hizo oxygen, ameongezwa maji, unaambiwa sasa ndio huyo mtoto wako mbalishe pamba, ujue ushike wapi, juu alikuwa mdogo. So mimi nikacha mtoto hapo nikaenda kulia. Nikacha mtoto nikaenda kulia, mama mwingine ndo akanisaidia akambalisha hizo pampers nini. So okay, sasa kisonga hivyo ndio nikaenda nikamwona nikambeba kidogo. Bali kwa mdogo bado nilikuwa naogopa kumbeba hata. Ikabidi tu nijikaze, sasa ni mtoto wangu.
Mimi hata baba juu kwenda nursery kufidi watoto tulikuwa tunatoka kwa ward.
So in the interest of time, I won't leave it for you, but there's a button available on YouTube and I'm happy to provide the link. But in a summary, what the mothers expressed in the interviews about the fears they have, there is issues that cannot be addressed at the hospital level and things that need to be addressed at the health system level. Just think about an NBU layout. NBU layout.
Crowding in our NBUs, lack of adequate facilities. We've seen hospitals where the sharing of beds, mothers who've got twin deliveries, and you think about how structured our feeding times are arranged, doesn't take into considerations the additional input that these mothers have to put in. They could be having issues at home, lack of enough social support from the family and the community level.
Sometimes we don't provide them with information, and remember they're getting phone calls every day from family members, and they don't have the information to provide when family members make phone calls about wanting to know what's happening with the baby. And some of these have other repercussions in terms of straining the social relationship that they have with their family members.
Yeah.
So it's there are myriad of issues that we need to address, and we need to combine forces across all sectors to find ways of addressing these issues. And quite critical, the post-discharge space. There's a big gap there. I won't go into it today because of time. So we need to work about on building holistic patient-centered care approaches, but also looking at it as a continuum of care. Starts from home, you get to the hospital, then you get home. Thank you.
Thank you very much, Dr. Dorothy Ogoch. Please don't sit. You've started very fast. Please don't sit. To our online viewers, we apologize for the black shadow that is covering your screen. We truly apologize for that. And we also apologize that you're not able to coordinate the sound very well for the video. Karibu sana. Please don't sit down. Lucy. Thank you very much. Dr. Lydia.
Good morning. I think I didn't introduce myself. My name is Dr. Lydia Okutoi. We are part of the hosts. Dr. Kinyuthia here is our host of the research center. Dr. Kamwig. Yeah, that is the real host. Then Sisi Niwale, the other host. I'm Director Healthcare Quality, and we are glad to have you here. We'll be having the opening ceremony soon. I think we can take tea. We have a dignitary who's coming to open this. As you know, this is a very key part of healthcare, so we need support. We need our big brother to own this, to carry this baby. So I think we will quickly do that, and then we are able to come back. So Dr. Kalondo, like 20 minutes. Great. So maybe we can say a word thanking God for the team. Father, we bless your name for this moment. We thank you for the refreshment you're going to take. I will take you with thanksgiving, Lord, as we commit into your able hands. You've been with us, and we're truly grateful. Let it be for our nourishment. And Lord, may we continue serving you in Jesus' name we pray. Amen. Great. So the dignitaries, or rather our panelists who are our chief guests, all of them, together with our board representative, we will guide you when there are like 2 or 3 serving points. I think we can take off right now. It will be good. Thank you.
Buda. Marketing walitutumia nani na nani? Buda mimi hapa tumejaribu kuplay ma videos, ma audio. Hakuna kitu, unajua sasa hakuna mtu anaelewa IPA. So hakuna kitu inacheza. Buda akuji, unaongea naye akuji. Nimempigia kama mara saba. Mwanzo imekuwa embarrassing ile si mchezo. Unaweza imagine presenter anajaribu kuplay video na hakuna hata kitu unasikiza. Hapa hakuna port. Zote zimechukuliwa na hizi devices zote. Yeah. But huku juu ulizia kwa hizi room za huku juu. Maybe okay. Ulizia tuko na nini? Hello? Hello? Hello. Hello. Kimbia kunywa chai bwana. Buda. I wish ungetoka. Ile kitu imenifanyikia hapa.
Na watu online wamesikia wakilament. Kuna mwenye amenicall. Atiambia watu wa mute.
Hello. Ndio. Bye bwana. Formal. Formal. Ka debe verga na migo tiene kuna. So ngonya bo nyakwa nini. Tuko tarete jot bwana kuna mweche kijana kalake ni. Arasi ko gai mawara jango diji. La gole mata har dale ya belia. Inya kita yas nyakya nyata mai ta ka jorwe ni na. Awale gi tukte jamba dai professional de belia. So tungo le zo dana wa jeb se oni. Koi mi ya da na mun gi gingen gele gunu kelia. Je go ne mun ne bi ga kelia manye. Kolom ku na ngwane ko am je tu kyo. Bola ga je sara. Go ruesa. Oh, madare wani ya. So, amage paise bond na the right way. Yes. Ano go ibu tina very low. Single it rendering and give carry on west. Lengo jeng ravi ni chere sebo komenga unaweka agere workshop bro iko kwa hii kama kwa sababu tu sio ngalejo ni kweli la kwan ngozera ngalejo ana independent opinion no lakini yeye ile
Gani unataka kucheza?
Nataka tu kumake sure stuff iko functional so that in the event kuna another video ya kucheza
Sasa hapa do you have any video?
Ilikuwa hii presentation.
Representing the board of management Kenyatta National Hospital. Daktari, karibu.
Our chief guest, our CEO, researchers, healthcare givers, good afternoon. God is good all the time. Thank you very much. First, I want to take this opportunity to thank each one of you for availing yourself this particular moment to contribute towards the success of this symposium. As you have heard from the CEO, my name is Dr. Wafula, but I like using double. I'm also Dr. Double. That double has a big meaning. I'll not tell you why. it means I'm too all the time. When you see me like this, I'm already double. So I'll explain. I'm really impressed by what this profession is doing. The medical profession in particular. Actually, I'm very much impressed. Me, I'm a veterinarian by profession. I'm a veterinary surgeon. And I'm the only doctor who got allowed to eat the patient. So when I see my patients, I might as well declare that this one will be my lunch, and that is not a crime. Can you do that yourself? It would not be a crime. Actually, I'm impressed by what this profession is doing. And the trend worldwide is to make our lives better. And human beings, through the wisdom of God, if you ask God, because he says, if you ask me, I'll give it to you and give you more than even what you ask, isn't it? I know you people, through the wisdom which is coming from God, you are trying very hard through researchers, to ensure that you make our lives better. And given that that is a trend, I know what you are doing today is happening all over in so many fields. Some other people are using the word participatory, like even in our field. When we are doing research, for example, with our patients, and you see now as we have the patients, which we don't speak to, we only speak to our clients, but we don't speak to the patient. You people have an opportunity to speak to the patients. As we just look at the patient, but as I said, I'm already, something's running in my mind. I say, this looks good. Can it be my lunch? No problem. But when we are talking about involving also the clients, our clients, we involve them in everything we do. That is where people are going, because that makes the whole thing holistic, as you are putting it. So me, I'm very much impressed by what you're doing, even what is happening today. Us as the board, we are fully supporting the management in their endeavor to ensure that they make our lives better. So today we have joined together here just to tell you that we are together and we support. And as the CEO said, given that I'm the employer, I allowed him to do this. Otherwise, we would not even have carried out this activity. Is that correct? Yes. I will tell him no. But because this is good, as a board, we said, support it, and we'll continue supporting it because we want so many of such activities to ensure that we all have quality life. So I prepared my speech. I'll just read it. You listen carefully, and then you listen with your 2 eyes, those are double. With your 2 ears, they are double. Is the nose 2 or nose is 1? Two noses or 2 nose? So don't speak, you have 1 mouth. Because I'm double, you have 1 mouth. Don't speak. Thank you very much. Greetings from the staff and the board of management of KNH, this precious occasion of the Patient-Centered Care Symposium, which is being held here at KNH on this particular day, 5th day of April 2024. Under the theme, fostering trust and compassion, elevating patient and family-centered care, we gather here today to underscore the importance of patient and family-centered care within our health framework. At our institution, we firmly believe that patients and their families are integral partners in their care journey. A truly holistic approach to healthcare necessitates their active involvement and empowerment. For instance, when a mother leaves a hospital with a sick child, we must equip her with the knowledge and support necessary to continue the care regime effectively. This can only be achieved in an environment that fosters support and respect, infusing a humanistic essence into our care delivery. Today, we shine a spotlight on the essence of compassion in healthcare. Compassion serves as the currency that enriches the technical proficiency of our healthcare workers. It is through empathy and action that healing environments are cultivated. As Dr. Patricia Werner eloquently advocates, compassionate care hinges upon the following. 1, a sincere desire to assist patients, families, and colleagues. 2, the ability to collaborate, communicate, and partner with patients and families. 3, prioritizing the well-being of healthcare professionals. As the Board of Management of KNH, we are deeply committed to ensuring a positive patient experience throughout the care journey. Our Clinical Governance and Research Standards Committee diligently monitors the quality of care through quarterly reports. These reports encompassing patient feedback, experience surveys, and staff sensitization initiatives on patient-centered care are pivotal in continually guiding our efforts to enhance our standards. Furthermore, the KNH board has consistently enacted procedures and policies that institutionalize patient and family-centered care, underscoring our unwavering commitment to this vital aspect of healthcare. We are delighted to see all of you gathered here today for this momentous symposium. We equally anticipate engaging in meaningful discussions to further imbue our institutions with compassion and empathy. Patient-centered care has garnered significant attention over the past 2 decades, recognizing that dignity, respect, and patient involvement lead to improved outcomes and enriched experiences. We embrace the 8 principles of patient-centered care, that is respect, access to care, coordination and care integration, information and education, emotional support, involvement of family and friends, continuity of care, and physical comfort. As we delve deeper into these principles today, let us reaffirm our commitment to providing care that is not only technically proficient, but also deeply humane and passionate. Thank you for your attention, and let us embark on this journey towards a healthcare landscape that genuinely prioritizes the needs and dignity of every patient and their family. Now I was reading the speech. A lot of Kibukusu was inside. Was I speaking Kibukusu? You are listening very keenly, I'm sure. But you could tell this one, and I could learn to ugali na busuma with the patients, which is good. So thank you very much for listening to me. I want to return this to the CEO so that he can guide us further. Thank you very much, participants, and God bless you.
Thank you. Thank you, Daktari. As you eat your patients, I'm sure you eat more chicken than, so you eat small patients, not the big ones. Dr. Chokwe. Dr. Chokwe is my teacher. He's an expert of also making patients sleep and wake up. At this juncture, we want to invite our chief guest. Please up standing. Dr. Harry Kimtai is a principal secretary, Karibu PS, and I would also inform you that we also have other participants who are online. Karibu Kenyatta sana. Let's be seated. First, let me start by greeting you. I want to say good afternoon. Really, I want to thank the management of Kenyatta National Hospital for organizing this symposium, and not just organizing this symposium, but also inviting me to come and officiate this very important function. The brief that I've gotten through the CEO about this symposium and how KNH is organizing trainings for their staff, and not only their staff, but all facilities, whether private or government. I really want to congratulate you for that very good and noble idea, because you are living to your call and your responsibility as a national referral hospital. National referral hospital means you are the center of excellence in each and every aspect that you are doing, and leading in this training is really important. I like your innovation, because you might have requested a lot of money to start such facilities, big facilities, but you've told me you've started small in a very simplistic manner. And again, looking at the theme of today, I so believe the ideas that you have in terms of looking at your patient is really great. So ladies and gentlemen, it gives me great pleasure to officiate the opening of this patient and family-centered care symposium, whose focus is on constitutional right for Kenyans, addressing quality of care. The theme, fostering trust and compassion, elevating patient and family-centered care, is a well-thought theme, and that is focused on the patients. This resonates well with the government's directions in ensuring that no Kenyan is left behind in the era of UHC. Patient-centered care is a concept that, ladies and gentlemen, I want to tell you that has gathered much interest in the last 2 decades. This important aspect of quality of care recognizes that treating a person, receiving care with dignity and respect, and involving them in decision-making leads to better outcomes and enhances patient experience. Again, that's a patient journey. It's every time the patient is journeying comes the different experiences, and it is important that you involve them in the right decision-making. Dr. Wafula has talked about these patients who don't speak. That one time I was leading that team as a policy head, and I used to find them very interesting team, because they are like, if you ask me, they are like magicians, because they don't talk to the patient. They simply give diagnosis and say this patient will be fine, and they leave that patient as well. But they say they come later on to find out whether it's fine, so that they take them out for lunch. And I can see it's something that is in all of you who are in vets. So you're leaving to your call. And as you are here also, and as you are here also, it's something that now we need to look at our patient and journey with the patient. Journeying with the patient is a very important aspect, because you don't leave the patient halfway. Journeying with the patient is sometimes calling the family and asking whether the patient has improved, is doing fine, and when they give you the feedback that yes, the patient is up and running and they engage in their useful economic activity that is going to support the family, you have the energy now to go back and look to another patient. Otherwise, you'll also be left midway without knowing what to do next, whether you are right on the last one and the one that you're going to handle next, what's going to happen with that one. So these are very important aspects, and
beyond just the technical correctness of healthcare services, patient care ought to be provided with what's called handle them humanely, because you are also a human, and therefore you must handle them humanly. These nuances are well captured in the 8 patient-centered care principles of respect, access to care, coordination, and care integration, information and education, emotional support, involvement of family and friends, continuity of care, and physical comfort. Research has confirmed that better outcomes are reported when the patients, families, and healthcare workers communicate effectively. This enables them to work towards a common desired outcome. And unless you communicate, you won't know the outcome. As I said, you will be left halfway in the journey because you are two and you have to journey together. If the other one parts leaves your hospital facility, you do not know whether that person's the medicine you prescribed has worked or not. It only depends if maybe you have requested them to come back so that you are able to get a feedback. But imagine a situation where they have not come back. So I think these approaches will really help us in achieving our UHC. Trust that I want to say has fostered during the clinical visits enables patients to follow through with the care plan even while at home. Patients being activated to engage in their care possessions to the extent allowable is a paradigm shift from the passive receiver patient in the patternistic treatment models. That means that it calls for us to change our models. We have to shift and make sure that in this era of technology, where we can even have a WhatsApp or a video call, you're able to see a patient. And that, if you're able to call a friend and find out how the friend is doing, you who are within the patient care, why don't you also find time to call the patient and find out how they are doing? And tell them sometimes even just to put on their video call, because you say, tell them that you're in a video call, I want to see you, because you're able to engage. So I think these are some of the issues that we need to look at, the paradigm shift that you're talking about. I know it might be costly, but if we have enough healthcare workforce, then you have time to take care of the ones that have come through your hands. So ladies and gentlemen, whereas the benefits of engaging the patients and families are well documented, the LMIC continues to have missed opportunities to optimize patient experience for better outcomes. Margaret Rook, in the Lancet report for high quality healthcare services, found that participants in LMIC had low levels of confidence and endorsement of their health systems. Kenya, I want to report that was one of the study countries in that research. Therefore, this includes us. That means the representative of that research includes us in the sense that what we are doing is a replica of what that research has found out. And the healthcare systems then ought to address the gap by engaging healthcare workers, training institutions and healthcare facilities in ensuring that patient-centered care is strategically used to optimize patient experience. And I'm very happy that today this symposium has again brought different healthcare workers from different institutions to share the experiences. What do they do that is different? I so believe that alone helps you to understand how you're handling your patient, because again, it comes with different facilities. When you talk of Aga Khan Hospital, for example, Nairobi Hospital, Tenwek, there are certain norms and standards that they have set that minimum, this is what they want to see. And I so believe that sharing this together with the now counties who are bringing them on board, and we want our counties to also come to that level where they highest institutions like Kenyatta National Hospital, Aga Khan, Nairobi Hospital have reached, because that is where every patient is focused. And sometimes I can tell you, they just imagine and just feel like if I reach Kenyatta, I think that's where I will get treated. That's where I will be healed. But it's not the case sometimes. It's just the how. It is just the perception. It's just what they know. We have cases, and I'll give you an example, where a family was making a request for us to approve through the NHIF for the patient to go for further treatment abroad. Now, when we looked at the situation and looking at the whole and the recommendations from the doctors in the report, they said, look, yes, this patient can be treated very well here. And because it was a referral, I also felt it is true. And I said, when I looked at the report, and I said, it's true. So I said, let me engage and actually it was one of my bosses who had called and said, there's a family which needs support. Can you please handle this? So I went back there with a lot of confidence, trying to say that we do have this in our country. So we are going to save your patient. We are going to save the family. They are going to travel. And please, we have this and these facilities in the following institutions. So I thought I had managed to convince them. Unfortunately, they said, no, we want to go to India. The patient has said, I just have to go to India. That means they've lost confidence. They've lost confidence in our institutions. They've never had a good story, maybe, coming from one of our institutions. And I so believe this symposium of patient-centric is going to send a message out there that now our institutions have changed. It is patient-centric. Can you imagine if we take this message across the country, that within our institutions now, we are now patient-centric? And I think that is what we need. This symposium should not just end with a few of us who have managed to come for this symposium. That means we need to take the message across and bring more for training so that we all talk about patient-centric. When you go to the consumer service sector, for example, they will talk of customer care. And it's a very strong word, customer care. They will go for workshops, they will go for seminars about customer care. How do you handle a customer? Now, for you, the institutions, especially treatment facilities that provide treatment, I think you also need to embrace that customer care. And the language here of customer care is a patient-centric care. So it is the same concept. But you see, we don't talk about it so much. We talk about it as if it is just one of those cases. It should be something that we live with it almost on a day-to-day basis. It is like our DNA, if I may call it. It's like our DNA. So that when you come to this facility, you just find yourself changing. If you have had a bad day from your house, you just find yourself that the moment you reach this place, you start changing, you start laughing with your patients, caring, talking to them. Just like Amuri has told us that he was asked, why haven't you gone for strike? So that patient knew that anybody call a doctor is on strike. That was what was going on in the mind of that patient. All right. So they never expected treatment. They never expected Dr. Kamuri to appear in the ward. But there he was. But I am sure believe that has impacted that patient differently. Differently in the sense that, so there are doctors who have not gone on strike. They are still coming to see us. So you can see the positivity in that patient. And that is the healing process. That is the healing process. That's why, my friend, I bet these ones are different. They talk to them. They can feel them. Right? And that body language that they exhibit at that time of communication is really, really important, because you're able to know whether this patient is in pain. So that's patient-centric. It should be something that we be part of our DNA. And I say this because in this era of the UHC, because now we're talking about UHC. When you talk about health financing, we're talking about for the purpose of achieving universal healthcare coverage. When you're talking about treatment, when you're talking about human resource for health, we're talking about UHC. So this is the era they're talking about UHC, and we therefore must bring all aspects that will lead to success or achieving our UHC. And therefore we are called to address access to care services. And while addressing financial barriers, we do know there are financial barriers to healthcare, which we are now trying to address. Because we have realized for a long time, the financial barrier has been an impediment in the treatment. That's why we have the Social Health Insurance Fund that we have developed. But we have gone further, not just talk about the Social Health Insurance Fund, and that's why saying that we have to be more innovative. We realize that we still, as much as we are having the NHI, which was National Social Insurance Fund, which now is the Social Health Insurance Fund, we now realize that we still needed some more funds. That is the primary healthcare fund, to make sure that at that primary level, this person should not start feeling the burden of finance. Those are the barriers that you're talking about. So that if they have gone to the primary healthcare fund, they have been treated at that level without so much cost, and they have been covered through the primary healthcare fund. And if the disease requires that it's supposed to be a referral case, then they can confidently walk to the level 4 facilities and come forward and say, I am sick. This is the referral system. I have been told that I need for further checkup. I need the following tests to be done. They walk in there confidently without this financial barrier. And therefore, that finance challenge, government has started addressing it by coming up with the 4 critical acts that were passed, which we are now implementing. And very soon, you will see this happening. So it is therefore imperative to take note of the quality of healthcare services. Quality services are effective, safe, and patient-centered. Again, I'm coming to the same subject. It must be patient-centered. At the end of it all, it must be patient-centered. So as our country rolls out the new healthcare financing model, we need to take note that we are committed to ensuring every financial investment adds value to Wanjiko. We have tried as a government, we've had challenges, specifically in our health insurance systems. We've tried to block some of the leakages of revenue, frauds. It's been very difficult. We've tried to do amendments in NHIF Act. We did it severally. We realized that we could not amend it further. And that's why it was decided that we have an overhaul. Now, most of us here have vehicles. You go to the mechanic, fix this, your vehicle is still making those noises. You go back, change mechanic from Otieno to Kamau. From Kamau, you now want to go to Mohammed. Then you realize this is too much, right? And the mechanical guys will tell you this. This requires an overhaul. That's the prescription. It is done. Or you doctors will say, this requires an operation. We have no choice but to go through that operation. We reached that level where we required an overhaul of our health care laws. That's why we did an overhaul and came up with 4 new laws, which we believe is going to help us achieve our UHC agenda. So distinguished guests and participants, as I conclude, care ought to be responsive and patient-centered from the lowest level to the tertiary level. As one presenter said, it should not be a doctor alone. it includes the groundsman. It includes the watchman who opens the door for that patient to come to the facility. If he communicates with that patient, just to ask, how are you feeling today? Welcome in. The doctor will be seeing you in a few. Please go and queue here. Get it? That very simple. If you train that security person at the gate, and even allow that security to start walking that patient to the seat. Now, if Kamuri says you treat and then you walk out and say, okay, utapona, but if you have not started with this security man at the gate, will your efforts, Dr. Kamuri, be, really have achieved? So again, you realize that you're all alone in the system. So you must start from that security, that gate man. Train that gate man on how to handle your patients. And I will tell you, when they go back, the message that they will pass, as much as they have been visiting Kenyatta, or their relatives have been coming to Kenyatta National Hospital, or Tenwek, or Aga Khan Hospital, or whichever facility in the county, they will go and pass the message because they visit each other. If they are ladies, they want to visit each other in the morning when they are going to borrow each other, I don't know, Nikama, Choka, the axe, or the whatever, and say, are you aware? When was the last time you were in Kenyatta? Do you know in Kenyatta nowadays, they handle people very well. You will just start meeting that watchman at the gate, and I say, sijui kama ni daktari pia, lakini alinishughulikia sana. You know, we come from the side. We come from our communities. We know what's going on in the communities. We know this word of mouth is more powerful than this advertisement, this media you people are doing. It's more than the TikTok. Because that will pass. And the one that, in fact, it will find another one that, do you know Kenyatta now these things have changed? And that perception about Kenyatta will change if it was a wrong perception. And you'll start seeing the number of patients that come to see you. And it's evident this, I can tell you, because when you go to the private clinics, before you go, you ask, which doctor is good? Daktari gani wa meno ni mzuri? Daktari gani wa hii ni mzuri? It is called a referral system. All right? So if you are not a very good guy in customer-centered, definitely you will lose because nobody even think of you because you are not within the lips of these people. So as I've said, let's start from the lowest level. I think this is what you need to do, Dr. Kamuri and others who have organized this. Take it like a customer care training. Don't call you as customer care. Yours is a patient-centered care. Because this team will come and tell you want to do customer care for your staff. No, yours is not customer care. Yours is patient-centric care. That's where the difference is. And you'll talk about all this, how to handle the family. You see, you're going beyond that customer. You're going beyond the customer by dealing with the family, the second person. You're not just dealing with that person, customer. You include the family, and that this team and this the team for the symposium really resonates very well in us as a government to achieve our UHC. So I trust that this gathering here in this symposium will foster a meaningful discussions, share insights, and exchange innovative ideas and ideas that on enhancing the patient-centered care within our institutions and across our broader healthcare landscape in the country. I want to thank you so much for giving me an opportunity to come and share with you some of it, part of my experiences. I want to share this with you. There was a time, I think, caring for a mom, And when I went to hospital, and actually we had gone to all the hospitals. All the hospitals. Kisumu, was those days living in Mombasa. I told her, come, we live in Mombasa. My sister was here in Nairobi, came to Nairobi. And then he said, now, you know, let me go home. But before I go home, let me go through Eldoret because our other sister was in Eldoret. There are very many doctors there. Diagnosis was not coming out very clearly. So we didn't know what it was. So that doctor friend of my sister said, let's do an X-ray on where she's feeling pain on her bones. She can't really say where it is paining. When they did X-ray, they found out that, and even further tests, they found out that she had multiple myeloma. It means she had problems with her bones. When you have problems with the bones, that means you just feel pain everywhere. You don't even know where it is. But you see, the doctor then identified one of the senior nurses and said, because I think the way my sister was relating with her, the doctor realized that they have started bonding. And she's the one who was told to go and break the news to us that your patient has cancer. You know, those days to pronounce somebody of cancer, you want to collapse there and there because you just know like the person is not there, isn't it? But nowadays we have a lot of chemotherapy, radio, and all these things you can extend the life of the patient for a long time. So eventually, because of that, they developed friendship. The nurse and my sister, now they would started visiting each other, asking how is it, because my mom was still there, going to visit. So they became so close. So you can imagine now, I'm just trying to tell you an experience, how you even extend your friendship. All right? You can extend friendship until you become family friends, starting to visit each other. So it's that close. And I think your profession calls for it. And that's why we used to say that unless you've been called, see, they say doctor, to be trained as a doctor is a calling. You must have that calling. So you can imagine that means you're closer to God, isn't it? You are very close to God. You are actually, if you take it in the context, you are that. Because we always pray that God heal us or heal the patient through your servant, the doctor. So live to your calling and let's live to this patient-centered approach or care as you've talked about. Thank you so much and may the Lord bless you. Tumpigieni makofi PS tena. Tumesikia, tumeelewa na tutaendelea kufanya. We will continue serving. Now I've been given a small task to give you, what do you call this? Unajua Dabo aliongea na Kiluya, mimi nitaongea na Kikalenjin. Unaita aje hii kitu? Sio hivyo. Sikusema imeandikwa nini. What do you call this thing? Oh, yes, nimeambia nikuweke lapel pin. Huh? This one looks like a tongue twister. Shika. Nani mwingine anawekwa? Dr. Wafula utawekwa na Lydia. Dr. Ngige utawekwa na Kalondu. Dr. Chokwe utawekwa na sijui nani. Kuja uweke Chokwe hapo. But Chokwe, you might meet somebody who is taller a bit. Ebu simama. Then Dr. Kinuthia. Where is saidia.
Kila mtu ashike hiyo kitu. Inaitwa lapel. Ama nasema inaitwa. Enda weka chokwe. You might need a stool. My friend, kuja uwekwe. Where is? Nani alikuwa ananiweka? Oh. Thank you very much, PS, and we really do appreciate. Tupigie makofi tena, asante. We will take a short break as we proceed, and we will have a group photo there with the PS and some, and then we will continue with the proceedings. Thank you. And I will hand over the program back to Lydia.
Thank you very much. I think we can stand up as we applaud our guest, our chief guest, even as he's walked out by our CEO. Asante sana kwa kukuja. Thank you. We can have our seats and we will be proceeding to the next session. If we would have a representative of the various institutions from the county, Nairobi Hospital, just to join us for the photo. You'll just be back shortly. The patient advocacy group, Aga Khan, yeah? Maybe it may take, yeah. If we can have just representatives. Faraja, Professor Chokwe, UON, yeah, kindly. Great. They will be back shortly, and then we can have someone help us, think, Paul, so that we get the seats for the next panel. Great. I can have Liz hold the mic and tell us something. Is there somebody representing InfoSpective in the picture? Joel, you want to represent InfoSpective? The patient advocacy groups, I hope rare disease, all the people who come here as panelists would want you to be at the back of that photo. Yeah, Tenwick, yeah, I'll tell him.
Okay, I think as we just get ready for the next session, I just want us to think a little bit about the different hats we wear. Are we all, how many healthcare providers are there in the room? Just show of hands. Healthcare providers? Okay, anyone from insurance, from the payer side? How many of us have had the role of a patient? Nobody. I'm wondering. I'm thinking you people are also healthy. You've never been a patient in your life, ever. You have? Have you been carers to patients? So I think for the next session, I want us to wear that hat of being the patient, not the person who is telling people, this is what you need to do, not the one giving instructions. I want you to the patient. Think about how your experience has been as you walked through the healthcare system, the kind of reception you got, all the things that you gathered from that experience, and how you would be able to tell people about that, if at all. And then we'll draw from that. So I think we'll just take a short break, and just let everyone finish with the photo and set up the stage, and just sit with that thought. Think about the last time you were a patient or someone with a patient. What was that experience like? Okay, thank you.
Good afternoon. Good afternoon again. Thank you for being patient. We thank our guests for being with us. That is not something small. It is a sacrifice, and we really appreciate that. There are some few things that they have mentioned, and I just want to highlight as we wait for our next panelist as they take their seat. So one of the things that the chief guest has said is that we need to improve the patient experience. We need to be patient-centric, and that should be our DNA. Our DNA should be being patient-centric, and I think this symposium, it is a key thing, because one of the things that the chief guest has said is that training need to happen. And even our morning panelists, one of the things that they said is that we need to take care of the healthcare worker. How do we take care of the healthcare worker? It must be through empowering them. And how do we empower them? Then we train. And this session is actually a very good one. The other thing that the chief guest has said is that we need to journey with the patient, and we need to invite the others. And the others here, we mean the other family members, the friends, because often or not, the friends are the ones who cater for the bills. They're the ones who take care of these patients. So we should not concentrate only with the patient, but we should think about the family and the friends. So that is very key. The other thing is that we need to optimize experience so that we can have better outcomes. And in the morning, one of the presenters, who was Mr. Makomi, did say that we should not just be competent, but we also need to be very passionate with what we do. So that is very, very key. The other thing is that we also must think about innovation going forward. How do we engage our patients in terms of innovation, instead of asking them to come all the way from Mombasa, from Kisumu, just to come for an appointment? Are there things that we can do using innovation so that we can optimize the experience, still be patient-centered in wherever they are? So that also came out. The other thing that he has concluded with is that we need to earn trust as we treat our patients. And how we earn trust, we need to be patient-centric. We need to involve our patients in whatever we do so that they can make better decisions. And Prof said, better decisions are made when people are aware and are involved. So we need to really involve them in that. And without much ado, I think we need to go to the next session, which is amplifying the patient's voice in healthcare. How then do we earn this trust unless we amplify our patient's voice? So I want to hand it over to Dr. Elizabeth Opondo, who will be the moderator.
Thank you, Paul. So I think most of the people who are in this next panel session are back from the photo session. So I'd like to invite them to the stage. So we have the person who did our opening remarks, David Makumi. Kindly join us on stage. Thanks. No, pick whichever one you want. And then we have Christine, who is the founder of Rare Diseases Kenya. Kindly join us as well. We have Peter Omolo. Kindly join us on stage. And a light down. Okay. Thank you all very much for honoring our invitation to come and join us today and give us a different view on this. We don't have a gender balanced panel. So do I have to go sit there so that we look a bit balanced? Okay. So before I tell you who I am, you've already just been told my name. I'm going to allow the panelists to introduce themselves. We can start with Christine, since we're doing ladies first.
Good afternoon. As said, my name is Christine Mutena. I am co-founder of Rare Disorders Kenya. That's a patient-led organization that creates awareness and advocates for people living with rare diseases in the country. And on a personal note, I am a mom to 2 kids with different rare diseases. Thank you.
Okay, you can pass it on to whoever you feel should be next.
Good afternoon. God is good
Assalamu alaikum to my brothers and sisters present. Thank you. My name is Ogalo Ogweno. I am sitting in for Mr. Peter Molo, who is one of our director. Our organization is called the Confraternity of Patients Kenya. So if you happen to have watched JKL Live, you might have noticed our organization was diversely mentioned, it was majorly mentioned. So COFPAC was formed in 2020. The reason for the formation was to champion for the interest of the patient. And one of the conversations very eminently talked about is one of the goals. It is really targeting the goals. And the goal is to promote patient safety and safe healthcare practices and system responsive to and centered on healthcare service seekers and satisfaction. I think we are really, really on the right path because, well, you are either a patient or potentially you are one, or you're taking care of someone. Thank you.
I'm the same guy who was here this morning. Hi. Yeah, not much has changed. The only thing is that I'm going to talk when I'm seated, which is really cool.
And Elijah?
Good afternoon, everyone. Thanks for having me, Lydia, and the team from KNH. My name is Elijah Ongeri. I'm immediate former chief nurse for Metropolitan Hospital, Nairobi. Also immediate former head of business at Metropolitan. I'm a founder of Institute for Patient Safety in Africa. I'm passionate about patient care. I like the topic, patient-centered care. Last year, I had an opportunity to present in a conference in Korea about patient-centered care. And I'm here to share the experience about how passionate you can be about patients. Thank you very much.
Thank you, everyone, for those brilliant introductions. And I hope that now, since while you were having the photo session, I asked the audience to shed their hats of professionals and to put their hats on as patients and patient caregivers. So that is the perspective we'll try and run this session with. The PS had told us that we should journey with the patients, but I'm going to go a step further and say we should actually partner with them as we think about the kind of care that we're going to give them and what actually matters to them is brought to the forefront. So my name is Elizabeth Opondo. I am a pharmacist by profession, but I found myself in a field called value-based healthcare, where we use this as one of the vehicles where we can champion for person-centered care, looking at the experiences and the outcomes that matter to patients and how that can be bridged with the investment in healthcare and design of services that are to be given to the people who are seeking care. So I think to start off, since I'm putting on my patient hat or person seeking care hat, I'm going to ask my panelists, how can they help me amplify my voice? Have you seen any kind of initiatives that maybe as the patient advocacy groups that you've done that can help amplify my voice? I've been through the healthcare system. I've seen so many doctors. I have all these experiences that are rich information that could help the healthcare providers take care of me better. How can I get that out into the right ears? I'll start with David from the far left.
Yeah, thank you very much. In terms of initiatives that attempt to amplify patients' voice, my good friend here just talked about an initiative, and I think the answer is just right there. There are a number of organizations doing a lot of work with patients. One of them is there's a caucus of patients, of persons living with NCDs, a caucus that seeks to just push the agenda of persons living with NCDs, especially those who need long-term medications or other issues around access to care. But that's a formal caucus under the Non-Communicable Diseases Alliance of Kenya. So it brings together people with diabetes, cancer, hypertension, mental health issues, everything that is not infectious. So everything else just would fall under that. So that's a formal caucus that has actually been engaging even with the Ministry of Health and other actors. So that's one huge initiative. But maybe even at micro level, there are many service providers that have support groups for patients. Patients either support groups for diabetes, for example, or support groups for persons with living with mental health challenges, or support groups for parents who have children with cancer or other challenges. So all those sort of groups were not just for patients or families to find support for themselves, but it's also a platform for them to be able to identify their issues, isolate their issues, and be able to present that as a united voice to their healthcare providers. I'll give you just like a case study. At Faraja Cancer Support Trust, every month we run about 10 support groups, different support groups. And when these patients come, whether they are young people, say, living with cancer, they'll isolate the issues that they have, that they need presented, either care providers or policymakers, or the areas that they have specific concerns. So that's a way, because these support groups are actually patients-led. If a support group is being led by healthcare professionals, then it's not a support group. It has to be by the patients, for the patients. You know the maxim that nothing for us without us. So the same thing, and I think it's a question of the healthcare system being open to empower the patients. We should be open to patients who are asking hard questions, giving suggestions, and demanding that which is rightfully theirs, which is quality care. I submit.
Thank you, David. So Gallo, I'll let you just let us know, are there ways in which maybe COFPAC has been empowering patients so that they are prepared to actually have these kind of conversations with the providers and the payers that serve them?
Okay, thank you. For COFPAC, we have been able to directly engage the public. We've been able to utilize the digital platforms, particularly Twitter and others, where we realize that most patients, the public who are either patient or taking care of a patient, where they're able to get the information. And we are planning for a webinar on mental health in the few coming days. We've had an opportunity where we planned for a webinar on AMR that was facilitated by Dr. Evelyn Wesangula. So these are some of the initiatives that we've undertaken on the digital platform so that we're able to reach as many people as possible. On the, he has mentioned something to do with communication. Communication is quite fundamental. It's very important in passing information and even allowing the patients to, give feedback. The feedback, you don't even need to wait for the patient to go home to do a video call or something, or even a call. As soon as you're done with the patient, you ask the patient, hey, are you okay? Are you done? Is there any other way I can help you? And so forth. So we are encouraging our patients in that way so that they're able to engage, the healthcare providers so that they get more information and they create, a relationship. Then we have also been able to engage the legislative arm of government. We've even been able to engage the ministry. So for on the same, we have a service charter. We have the health, what is it called? The National Patient Service Charter, which is known by healthcare workers. I know majority do not really do not even know the 10 points on on the charter. So these are something we asking the healthcare facilities to have them displayed. A patient comes, they see their rights, they're even able to make inquiries, and even displaying those, the charter is able to empower the patient to ask more and even gain more as to improve their healthcare outcomes. So thank you.
Thank you so much. So I'm just thinking back to how they say that there's power in numbers, but in the case of rare diseases, the numbers are not really that many. So Christine, from your experience, what are some of the ways that you've been able to empower the patients who you represent, and maybe help build a partnership with some of the healthcare facilities so that their voices can actually be taken into account?
Okay. What we've done mostly is engage also the healthcare providers, enlighten them, tell them that we are people living with rare diseases, lived experiences, so we are experts in our own rights. And I would like a seat at the table. So we have CMEs with different institutions, pediatricians, doctors, we've had even Gertrude's Children's Hospital trying to address from the lower level of kids to even physicians. So for us, it's about one-on-one and also trying to tell our members that you are the expert, given that it's a rare disease. You know more than what, no offense, doctors have learned in school, because I'm told the literature is small when it comes to rare diseases, and given that there are over 6,000 rare diseases, you've not been exposed to all of them. It's mostly tropical diseases and all that. So you know more. So it's also about approaching the doctor with respect and telling them, this is what I know, this is the literature, because half of us have folders with details about our conditions or our loved ones' conditions, and we go with them to the doctors and we tell them, look, this is what we're dealing with. Let's talk and let's discuss. Yeah.
Thank you for that input. And now I think, Elijah, as you're a health systems specialist in the house, from where you sit, have you seen any initiatives where a good partnership has been forged with patient advocacy groups, or where there are channels that actually help bring out the patient's role in their care?
Thank you. We are in healthcare, we are delivering sustainable development goal number 3. So that's where it begins. Sustainable development goal number 3 talks about ensuring the well-being, not only of individuals, but the communities that surround us. 3.1 talks about maternal health. 3.2 talks about neonatal health. 3.3 talks about NCDs. Go down the list, tobacco control, road traffic accidents. That's all our mandates. Now, when you narrow down, come to the country, there is a lot of things that we need to do for the patients. And yes, there are initiatives that are happening. For instance, the WHO calendar is clear on the specific days, specific months that we celebrate with different conditions, because as she mentioned, over 6,000 rare diseases. We have the World Autism Month happening now. In the morning, one speaker spoke about previously, I think it's Dr. Chokwe, we didn't know much about autism. Autism is happening this month. So as providers, what are we doing about autism? How much are we engaging with communities with autism? It's rainy season. People with sickle cell are going to present in crises. So what are we doing about people with sickle cell during this season? In my previous work, we had an arrangement with Sickle Cell Foundation, Children's Sickle Cell Foundation specifically. We had a sitting. For the longest time, we thought we were doing the best for the patient with sickle cell. But unfortunately, we didn't, because we thought once they come in, they go, we triage them first. But we discovered we don't need to triage them first. They're coming in pain, address the pain and then triage. So once we had that sitting, everything changed, because now we are focused on what has really brought you here. And then after we address what has brought you here, then we talk. So it's so important that we engage these groups like rare diseases, autism, sickle cell, and other diseases that different individuals are suffering from. If the advocacy groups, we partner and we work together. I have 4 Ps that I always use in the approach of communities and diseases. Number 1 is the provider. Of course, patient comes number 1. So the provider is there to provide right?
Thank you so much for that, Elijah. And I think what has actually hit home with me, from what Christina said and from what you've said as well, is that the patient is the expert in their health. And so actually, if I put on my patient hat and I'm ready to give some feedback and to participate in designing services that are ready for me, what are some of the barriers that I might actually come across as I travel this path of actually getting my voice out there? So I think we can start with David and then Mike this week.
I think the barriers that as a patient one would encounter trying to position. We all know that the healthcare system is essentially paternalistic. True, false, ish. Yeah, we are socialized to a healthcare that we got to be told, we got to be treated, we are sick. The healthcare system has the answers. So we go, we are not there to make suggestions. We are, the business that takes us there is to be treated. I mean, maybe that is changing slowly, but there's the socialization, the traditional view has been, it's a healthcare system, we are consumers, we are vulnerable, for us to go to be treated and to make suggestions at the same time, it doesn't seem quite compatible. So that's one of the barriers. It may just essentially view as patient. Maybe the group that is here, we are all converted, but it's not easy across the larger healthcare system. Even in the private sector, it's not an easy walk in the park for patients to have representation on the table where decisions are being made or where things that concern them, decisions that concern them are being made. So that's one of the barriers. There are those kind of systemic barriers. And there are obviously also institutional barriers as well. People say, oh no, according to our policies, patients can't do this, patients can't be in this kind of forum, or, and we always hide behind, there is also confidentiality and all those sorts of things that will put a barrier to a patient being able to articulate. So maybe the lack of established mechanisms for patients to constantly engage, not to just fill a questionnaire, a little questionnaire and put it on the feedback box, which probably doesn't get open for 6 months. You just throw it there, nobody, addresses it, or send an email to an info address, complaints at whatever institution. That's not good enough. There has to be a proper engagement where the healthcare system is also proactive, reaching out to the patients so that they're able to be very clear. If I go to this institution, this is where I would channel my suggestions. It's not always that patients have complaints. Many patients have good suggestions, they have good feedback, but they just don't know who to tell and how to tell it because the mechanisms are either complicated or they are archaic. They just little boxes, they are feedback boxes. So that sort of thing. But also as patients, as consumers, I think we need to be empowered enough where the doors are closed. I think we just need to pick those doors, get ourselves in. And if we don't have a seat on the table, come along with a seat and just be there. I mean, I'm wearing my advocacy hat now, but I'm not saying literally just break the doors, but we need to find a way of networking and making sure that we are always included in such forums.
Thank you so much. And now, as you've told us to bring our chair, I'm going to turn to Christine because I know she's actually had positions internationally representing patients with rare diseases. Is that correct? Or am I making it up?
I can see you Googled.
I told you I did. I told you I did because I had to know who I'm sitting next to. So I think let's zoom out a bit and think about in the global arena, what have you seen as some of the barriers that are actually still there for patients who are trying to get their voices out? And are there actually any good practices that we can maybe borrow from that perhaps people in the group might be able to see how they can apply when they go back to their various stations?
Okay, one of the biggest barriers is cultural and social factors. We can't ignore that in terms of there's some cultures where the ladies maybe not allowed to talk with the doctor or the clinician, and it's only the male partner or representative who can. So you may not articulate exactly what I'm going through because I'm not talking for myself. So that is a barrier on its own. Globally, you find patient advocacy groups are very strong. It's actually in Africa that we are still growing, quote unquote, and for this I'm talking about rare diseases. But the fact that we are talking about rare diseases and telling people that, look, they do exist. You may not, I think the doctors, you can clarify me here, there's a phrase that goes, if you hear hooves, think horses, or something like that, about don't always assume it's not a rare disease. When it comes to repetition, think of a rare disease. So even when we're talking about urging our patients, go to the doctors, enlighten them, deal with other disease-specific support groups, get data from them, share with your clinician. For example, I told you I have 2 kids with rare diseases, so I have 2 folders, and each folder has a write-up of what they have or what I think they have, because one is not yet fully diagnosed, and what the doctors or her practitioners should be looking out for. So we are not fighting fires, but we're actually preempting those fires. So you find that's what they are doing abroad or in the West, and their doctors are receptive of that. So back to doctors in training, accept that we do know, not like before, we are aware of what is going on. We might have used an online version to get our knowledge, but it's still valid. So just ensuring that you are listening to the patient and the patient is feeling listened to. And I don't know who said it early in the morning that patients actually have a bigger voice now in the ecosystem, the healthcare ecosystem than before. And that is trickling down to Africa, but we need to give them way, give us way to actually share and make informed decisions as part of a decision maker for the condition. Thank you.
And I think that's the next place that we'll segue into, is giving way to people to be able to give their information so that it can actually be used by the healthcare providers and the payers to provide services that actually meet the needs of the people that they serve. So I'm going to ask Ogalo, you'd talked a bit about Twitter. Are there any other ways that you're leveraging on digital tools and innovations to actually collect some of this feedback from the patients you represent?
Thank you. So we utilize Twitter, for example, in a number of ways. We get even information through our inboxes. We also get information through our, because we've tagged our email on the Twitter handle, we have also been able to tag our phone numbers. So we've also been able to get, communicate with the population through those platforms. Of course, that now opens up to, broader perspective on how to get information from the client. However, I wanted to respond to those barriers, and I believe there are healthcare workers in this platform. And as you leave this place, we want you and pray that you're going to be ambassadors of what we speak on behalf of the patient. So one of the major barriers is stigma and fear. Stigma, fear. Basically, some of the information we've gotten, particularly touching on the stigma and fear. For example, Kenya is looking forward to eliminating HIV by 2030. And one of the strategies is the use of PrEP, to exposure prophylaxis, TDF, FTC, that's tenofovir emtricitabine. And of course, on the same line, we have teenage pregnancy being an issue. So our client goes to, our population goes to visit a healthcare provider and they tell them, hey, why do you want PrEP? Why do you want family planning yet you're still young? Something of the sort. That is a major barrier that is really hindering, service provision. Then fear is another thing. We got information that there is one of the member of parliament who was seeking for healthcare services within one of the facilities. And that something that came out of him was the fear, safety, safety, particularly medical errors, surgical errors, and so forth. So I think we need to create a culture. From our end, we are proposing the establishment of National Patient Safety Authority. That is amendment of Act, Health Service Act. But again, we realize that the ministry is also already working on quality improvement. So we wanted to insert the aspect on professional duty of candor. So for the professional duty of candor is whereby a healthcare worker is able to explain to the patient the prognosis, and is also able to explain to the patient what are the likely, complications of the form. And even so, should there be a complication, they'll be able to, be accountable. That is professional duty of candor. Then poor attitude, that is provider attitude. Then of course we have legislative barriers, poor communication and jargons. You are a pharmacist, as you mentioned, appreciate. Interestingly, a patient is prescribed something and it's scribbled. A patient is not even aware what the prescription is meant for, the diagnosis, the indication of the medication, they are unaware of. They take the prescription to a pharmacist or a pharm tech, and they submit it, and the pharm tech is not able to see it, the pharmacist is not able to see it. So what happens? Wrong medication, medical error, and so forth. Don't we think this is a barrier? Thank you.
Okay, I'm going to defend my profession. Sometimes we also phone a friend, and we have platforms where we do actually share what has been scribbled. And if that fails, we also speak back to the doctor. So hopefully that's what everyone practices. So now we're at the point of this conversation where we have patients who have been given the tools to be a bit empowered. They found communities where they can have a joint voice. They're giving their feedback to the facilities. So I'm going to ask Elijah, now as facilities, what can we do with all this information that now is going to start trickling our way?
Thank you, Doc. I will go back to primary healthcare. All of us who are clinicians, at some point when we went to school, we studied primary healthcare and principles of primary healthcare. And then other pillars of primary healthcare. Number one is universal access as a pillar to primary healthcare. How accessible are we as healthcare providers? This week is my first week with the Aga Khan. And the first question I asked in the office, whether when my mom is sick, we'll be able to afford Aga Khan. What I didn't know is that now I'm learning is that if you go to Aga Khan in Narok or Nyahururu, the consultation fee is below 1,000 shillings. And I asked, how did you get to less than 1,000? It's through stakeholder engagement. Stakeholder engagement is part of primary healthcare. Once you receive the feedback, what are you going to do with it? You need to have, someone mentioned about committees in the morning that handle patient issues. I think Benta and Wesonga talked about engaging patients, having patients, officers whose work is basically to receive feedback from patients and implementing it. In the hospital setup, we have people whose work is basically to stand on the side of the patient, and their work is to defend what the patient is saying. It might not be seen to the public, and I think to the public of organized groups, we need to have such, whereby when we are discussing issues related to patients, we let them in to be part of the process. For instance, patients may not know if something wrong happens to a patient, clinicians will call themselves to a corner and discuss about it. How often do we get them to the table? In my previous practice, if something went wrong, I'll always want the patient on the table. Let's have a candid discussion. Nobody wakes up to a healthcare facility to harm anyone. Nobody. So why are you scared when something wrong happens? You've received feedback, I'm not happy as a patient. Why are you not letting me come and sit in that table and discuss about it? We are healthcare workers. Why can't we allow patients to come and sit with us? Imagine as a nurse, as a doctor seated there, by accident, you are given a medication and almost killed you through a reaction. You'll expect an explanation. And it will be done because you know what it's about. So your colleagues will come and explain, this is what happened, it was a mistake, or it's something that we didn't anticipate, and you'll be happy with it. What about someone who is not a medic and it happens to them? For them, the first thing they think is foul play. But the moment you bring them to the table, they'll see that you really care about them and you've taken your time and you are here to discuss exactly what happened to them and you are willing to solve it. I always tell my teams, if you have a patient you label as difficult, bring them to me. Because the only thing I'm going to do, or the only magic I'm going to play is listen. Because it's what normally happens, you have feedback, you know the answers, you don't want to say exactly what it is. The patient thinks about something, they're holding into it, there's no platform to discuss. So there is information asymmetry. As a clinician, you're well empowered, you've seen every single aspect. Maybe this patient who got a reaction or an unexpected event is your 5th one or the 10th one or 100th one. And you know exactly what you did to the 10th one and you solved the issue, but you really don't want to discuss it. Information asymmetry. Patients are empowered. And these patients come from families, they come from institutions. The moment we receive that information and keep to us, we are being unfair to us first, as providers, and then second to the communities where we come from, and third to the patient. So we need to provide a platform to discuss. For me, that's the only solution to, if you receive feedback, sometimes what I've done before is, a patient has complained bitterly about a surgery that went wrong. Get the surgeons, get the nurses, get everyone who was involved. Put them in a Zoom. Who told you the patient don't know how to use Zoom? Get them in a Zoom, let the patient address the clinicians. You will learn lessons that you'll never think about. Because most of the time when you go to surgery, patients are sometimes sedated from the reception. So they don't end up seeing the beautiful theaters that you have. The surgeons are masked, the anesthesiologists are masked, so they don't get to enjoy theater. So they only survive to see the end effects of surgery. They don't know how serious people take that process to get you out alive after 5 hours, 10 hours of surgery. So if we allowed them to understand the process of what happens in the background, our life will be easy. And then it will be patient-centered care.
Thank you so much for that input. I think what we've seen is that we need to, as healthcare providers, give the space for the patients to actually be able to give us feedback, listen to them, and actually understand that they are the actual experts in their actual condition. And for those who are on the patient side, don't feel so shy. Speak up and say what is your feeling. If you have questions, ask, because the providers are ready to listen. I'll just open the floor, give space to other people so that now we can hear from you in case there are any questions for the panel, and as well as from the online audience.
Anybody with a question? We pick two because of the concept of time.
Good afternoon. It's a very interesting discussion. Thank you very much. My concern is that currently, mostly the feedback that the hospitals and the healthcare providers get is through social media. And majorly, the blogs where somebody creates a story of 6 months ago and now they are ready. They have recovered fully and they are ready to shock the world. And they have followers and they give a detailed story about their experience. And now my question as the institutions of advocacy, what is your role in this? What have you done towards this? Because we have healthcare providers who have been criticized a lot on the care that they give, yeah? And even the cases which happen as in instantly, when a case is aired on national TV. How do you demystify, what is your role in demystifying what is circulating in the social media and in the mainstream media?
Okay, I don't know if I'm answering your question or expounding it. Personally, I have a case in my computer. I'm just waiting for my peace of mind so I can address that institution for something they did to my daughter. And now to try and answer your question, as patient advocacy groups would be best if you as a affected family member or loved one come through us rather than going through those channels, because it doesn't help in terms of communication. She said, he said kind of discussions. But if you make it through a formal, and I think most institutions have formal reporting channels, but it should have more weight, more water if it came through a patient advocacy group. Like, for example, if you had a rare disease and you came through me or my colleagues and we went through that institution directly, it would hold more weight, more credibility, regardless whether it happened now or 6 months ago. Because the only reason I haven't pursued that particular institution for my daughter's sake is because I've been busy. I've been trying to get time to heal. So the time frame doesn't have to be immediate, because you have to be there. You have to be there first for your loved one before you can go find justice for them. So I'd advise you to go through the patient advocacy group that is related to your condition and or the institution, if you don't have a PAG, and actually just do formal procedures. Going online just fuels it and just makes somebody look bad, whichever party, and it doesn't solve the solution. That's my take.
Before I pass the mic, I want to make sure that I understood you, or rather I got you right. You are the healthcare provider and your name is really, being run around in the social media and so forth. Now, I think the gap here is communication. The gap here is communication. We've had many cases that are being presented to KMPDC, that is Tribunal Committee dispute. And we have gotten expert opinions for those cases, even gotten lawyers or advocates to help with those cases. But one thing we realized in those circumstances, the reason that led to that was the communication. Unfortunately, the healthcare providers do not give an opportunity to patients to be able to fully express themselves and even express their dissatisfaction. So would you have given an opportunity, then the social media thing wouldn't have occurred. So I think on a way forward, we need to converse on ways forward. How are we going to prevent such? Is through encouraging the use of professional duty of candor. That is, where you realize there's a mistake that occurred, you explain it to the patient, you talk through it, you talk it out, so that you don't end up, having your name being displayed on the social media. In UK, professional duty of candor is really working. We're really trying to push it in Kenya so that the healthcare providers are able to open up should an issue occur, so that they get to resolve the issues before a name of a hospital is destroyed, a name of a healthcare provider is also destroyed. So I think it's just a matter of proper communication and engagement with the client and provider. Thank you.
One more question. Well, Erija, do you want to, Daniel, do you want to say something?
No, okay, David. Just a very quick addition, but in addition to what my colleagues have actually very ably said, I think it's also important for us in the healthcare system, our healthcare providers, to be very deliberate, very, very intentional in seeking out feedback from patients and creating an environment, a culture of openness, of reporting, so that patients feel comfortable and feel safe. A safe space where patients can actually report before they walk out of that gate, whether the incidents had adverse effect on their health or not, or whether it's a system improvement suggestion. I think we need to be very intentional in creating that sort of space where people can actually come back to us. If you look at like the media, I think one of the media, print media has a public editor. I think one of the newspapers has a public editor where you can open up and say things around stories that maybe were not accurate. We may not completely eliminate social media chatter, whether social media is just that, it's open. We may not eliminate, but if we do our part as the healthcare system in ensuring that even if you go to social media, the mechanisms for you reporting were open, and we proactively seek out these, then we may be able to mitigate some of the damage. But I think we have to do that intentionally and continuously, not one-off, but it has to be very, very intentional. I submit.
Yeah, David has maybe already given part of the answer to my question, but there are very many individual stories, and we have said we should learn to listen and, not be patronizing so much. But how can we as a system also learn, like if something happened at KNH or at Aga Khan, how can Kijabe and Metropolitan maybe also learn from it? And how to like away from individual stories between patients and doctors, for instance, how can then also they get to the top decision makers, for example, or maybe more distance from the patient voices?
I think we'll just take one more for the interest of time, so that our panelists can answer both of them.
Thank you. There must be good news. It can't be all about, I went to the hospital, I got injured. KNH has 1,600 registered beds. At any one time, we have 2,500 beds. Patients. We don't have 2,500 beds a day. We have significant discharges and patients who come in. We don't say there'll be no adverse effects, even on the drug checks. You say the drug. We don't say we will cure everything. You must be honest with the patient as well. When you come to me, tell me, I have been treated. Mitishamba, Dr. So and so, I'm coming to you as a third report. When I fail to treat you, it's probably the complications of other things that have been in there that may have set it. But because I'm the last person to have touched you, no one in the media fault. If I cure you as well, after you've consulted everybody else, please get her out there and say, I was in KNH, I was in severe pain, I was treated, I am healed. Find out how KNH does this time. When we get a complication, everybody believes doctors and nurses and whatnot cover one another. You have no idea what goes on in the ward round, for example. Patient was admitted last night. Probably the drugs that we wanted to give the patient or are supposed to be given or not given. The consultant walks in the morning, the ward round stops that patient because we want to sort of that particular patient. There's nothing hidden. But what is presented, sensationalized, demonized, is that one thing that goes wrong. And unfortunately, it's true for the rest of the world because negative news sells like nobody's business. Positive news does not sell. Advocacy groups must also put in that positive. You must not just insist on getting your seat on the table to demonize people, but you must also sit there to make system improvements, better outcomes. When you go to a district hospital that has no access to blood, testing equipment, and the like, you don't put the hospital administrator as the day. The government is supposed to fund this. Are we putting them to task? Thank you.
Let me hand it over to Elizabeth.
David, before I give you an opportunity, Elijah had something to comment about one of the questions. So I'll just give him an opportunity.
Thanks, Joel, for the question. So we clinicians always write about successful case surgeries that they've done, complex heart transplants, kidney transplants, reattaching a cut off hand and all that. We also need to write stories about social things that happen in healthcare. Last year, KNH got a standing ovation in a conference hall in Joburg. Lydia was there. I was presenting on operational excellence in healthcare. People stood for KNH because South African doctors who were in a trip to Kenya got an accident along Nairobi-Nakuru highway. A non-African man brought to KNH casualty. They were sorted, taken to theater, emergency treatment given. None of them was in a state they could talk. Treated. 3 days later, that's when they discovered they were South Africans and they were medics. Nobody knew about it. And they're stable now. And the embassy can reach them and the other teams can reach them. But they were served. That story never went anywhere in the media because they were foreigners. They didn't know where to share this kind of story. So we need to publish as many good stories as possible. This country, I've worked in West Africa. This country has one of the best healthcare systems in Africa. Our healthcare workers are among the best trained in the world. There are only a few things that needs to be done. Healthcare financing. Once we sort that out and human resource for health, things are good to go. Then we'll need to concentrate on the emerging diseases, the rare diseases, and all other aspects of patients. And just like Professor Chokwe said, we want to hear more of Christine in healthcare. Come sit with us, tell us on how to improve. When we go wrong, of course, sometimes we are crucified, just like Jesus was done. And most of the time. But if we also publish of good stories that happen, don't leave publishing to clinicians. The customer service center needs to publish the compliments that we get every single day. Because there are so many compliments. Even when people are saying thank you, instead of them saying by word of mouth, give them a piece of paper, let them write, take a photo, post it somewhere. Because some of the conditions that bring them here, someone else is suffering somewhere and they don't know that it's happening because there are thousands of diseases that you're treating every day and nobody knows about it. So we need to publish as much information as we can. So there is a lot that is happening in this country and people don't know about it. When I went to Sierra Leone during Ebola, I was working for one of the international organizations. In Sierra Leone, if you're diagnosed with kidney disease, that's a death sentence. And that's as soon as 2014. Death sentence. There are 20 doctors in that country, 21, 2, 3, up to 20. And I always challenge Kenyan doctors, why are you complaining there's no work and there are no doctors in the West of Africa? And Kenyan patients, I'm also challenging them. Why are you complaining the healthcare is bad while you can afford to go to the nearest clinic and get medicine from a pharmacist? So patients need to stop kukua wajuaji, especially healthcare workers also. Don't medicate yourself. Don't come to the healthcare system when you are too sick to be helped. Healthcare workers will do that. Patients are worse now when they have Dr. Google. Dr. Google tells them, I think you have malaria, so you'll go for malaria medication. So you are coming in when it's too late. So when we get such stories of things that went right, we need to publish them and publish them to the local language. Get it to Inoro TV, Inoro radio, let people know about it. There are so many bad news in this world. We need to hear some good news. Thank you.
I think I'll just ask everyone to just give a 10-second parting shot, just so that we can wrap up the session.
Mine was actually just quick response to Joel. The mechanism for institution sharing knowledge and learnings from any, whether it's centennial incidences or critical incidences. If they happen to one institution, they could happen to another. And I don't think, to the best of my knowledge, there's a really proper established mechanism where an institution would learn from one another, unless, you know, presentations in maybe scientific conferences and meetings. But, you know, if that is to wait for once a year as a case presentation, that's too far away. Maybe there is need to think something around institutional sharing on patient safety, patient centeredness, so that lessons learned in Kenyatta can be shared in MTRH, can be shared in Coast General, or wherever. Maybe there's need to think about that. And for Professor Chokwe, when patient advocates want seek to be on the table, it's very often to provide solutions, brilliant solutions actually. So not always to bash and fight. Okay, sometimes we do that, but very often we want to provide solutions. If I give the example in the non-communicable diseases and cancer control space, actually nearly for all the policy documents, strategic planning, and all those sorts of things have actually involved people living with those conditions to contribute to National Cancer Control Strategic Plan and even the current NCD strategic plan. So the patients' representatives themselves are on the table to say how they want this to look like. We are always not on a war path, but we are there to provide solutions. I submit.
Okay, thank you. First, parting shot is I want to thank KNH for organizing this, you know, forum and being a center of excellence. Quality of improvement encourages copying. You can copy. You can copy Amalua shamelessly. You can copy shamelessly. So I think these platforms should be open to as many people facility as possible. Sharing of best practices, as probably was formally done, so that they can be replicated in the rest of the other facilities. Some of the other things we've been looking forward to is to ensure that the patient safety and patient-centered learning is is integrated into the professional development, so that as someone goes to renew their license, at least, because we've tried to push for this, that as someone goes to renew their license, they have gotten a short, studied a short course on such patient safety and patient-centered learning. So we're looking forward for more partnership with even any institution that is willing to work with the COFPAC, Confraternity of Patient Kenya. And just to let you know that COFPAC is a non-specific disease. We're not specific to any condition, because we believe there's so many ways that we can, work together with, the institutions as such, and even the healthcare workers. We previously worked with the KMA, COC, the Nursing Council, and so forth. So for us, we have an open approach for work to ensure that we have a quality improvement established to those respective facilities. Thank you.
Okay, for me, my parting shot is that as a patient advocacy group, we would like to be part of the decision-making process. We'd like to be a multidisciplinary team where the patient is a partner on that table, not necessarily the end of the seat, but we'd like to be partners. So we can have a shared decision, we can have a shared, because we do have a shared goal at the end of the day. So whatever happens, whether it's good feedback or bad feedback, it's shared on that table, because we're all partners. And I do believe partners do have the goodwill of their peers. So for us, that's what I would like would be my parting shot. Thank you.
Thank you for the invitation. My 4 Ps. If you want to deliver patient or person-centered care, number 1, get the patient on the table, and the family, of course. Get the provider on the table, get the payer on the table, and the promoters, who are the advocates of healthcare. Lastly, if the patient is complaining or the community is complaining, ask them, what's the end game? If the end game is money, it's not objective.
If the end game is to solve the problem, solve it. Thank you.
And I think with that, we're going to wrap up this session. And hopefully we've all gotten something from this. From wherever we sit, whether it is from the provider side, the payer side, or the person seeking care, let's all try, and my call to action for you is to try and have engagements that are transparent and honest, so that when there's things that go wrong, we can work together to fix them. And when there's things that have gone really right, let's also celebrate those. Thank you all very much. And I'd like you to give a hand of applause to our panelists. They'll still be available in case anybody wants to get in touch and foster a new partnership. Thank you all.
Before they leave the stage, I think we need to give them a good applause. They've done a good work. We've learned, haven't we? Okay, let us give them a good one. Thank you. Thank you so much. And also thank you for your patience as we almost finished the last panel. I'll ask our director to come and hand a token of appreciation to our guest. Thank you so much. Thank you so much, Christine, and welcome to KNH. Kofbak, thank you for the partnership. I think the conversation has already started, and we hope to have more of this. And to our able moderator, thank you so much, Elizabeth, for the good work. Let us appreciate them one more time. Asante sana. So our last panel discussion, which is between us and lunch. I hope it to be a very long one, but it is very informative. It is on establishing an ideal environment for patient-centered care. We've talked about elevating the voices, fostering compassion. Then how do we then make this environment to be ideal? And I want to ask our director, who will be the moderator, Dr. Lydia Ukutoi, to come up, and our panelists. We have Frida Rangat, Dr. Davis, Esther Karuku, and Ayub Arembi. Karibuni sana.
Thank you very much. Do you want to stretch, to stand and stretch as we start this last session? We hope to take not so long, an important session, but if you can realize you've just been going towards climax, you've been gathering more and more. Yeah, you can stretch, different. The people here don't want to stretch. No problem. Is Dr. Davis with us? Anybody from Kijabe? Great, so we can have our seats. Indeed, it's been a great day. When I was listening to the patient advocacy groups, I remembered last year we had the Patient Safety Day. The theme was engaging the patients and their families for safer care. And one of the guidance from WHO, they develop a toolkit called Storytelling Toolkit, whereby the patients can tell their stories. We can go to the website and just find out what that is about. But there was one big thing called what if, enabling patients to say that word, what if, because I'm technically not competent to know how the cesarean section was done, but I can ask, Daktari, what if this happened? Is it possible that this would not have been the outcome? So it shields the patient from trying to interpret medical things, but can just bring their emotions that I'm wondering, such that we know that the patients come to us both in their body, they're intelligent being, and they can ask questions. And so teaching patients to use that word, what if? Yeah. What if you washed your hands? You said sepsis. My baby had sepsis. What happened? What if I did not give these feeds? They both ask themselves, they should ask the system, so we should allow those healthy questions. And so I'm very glad. Thank you very much, the members of my panel. Thank you, Ayub and Esther and Frida. You represent important aspects. So we've been talking about the other aspects of patient-centeredness. Now would want to zero in on the enabling environment, but especially just to get lessons about what has worked in our institutions and what do we think is there to foster this enabling environment. Because when we say dignity, compassion, they just look like soft things hanging in there. So when it comes to Odaya, when it comes to Tenwe, what does that mean? And before we get into that, I think we'll have a short introduction of what you do and the institution you come from. We'll start with Ayub.
Good afternoon. Thank you so much, Dr. My name is Ayub Balembi. I work in Kenyatta National Hospital. I'm a health information profession, and I have an experience of about over 27 years in Kenya. Thank you.
Thank you, Ayub.
Hi, good afternoon. My name is Esther Njeri Karuku. I work in KNH Odaya, which is also called Mwai Kibaki Hospital. So I usually coordinate patient safety there. So I'm actively engaged in making sure we have patient-centered care. Thank you.
Thank you, Esther.
Good afternoon.
Good afternoon.
My name is Frida Kiptui Langat. I am a family physician. I work in Tenwek Hospital. And being a family physician, the family and the community is in my heart. So I'm very happy to be here today. Thank you.
Thank you. So as we've realized, they all represent different aspects of healthcare providers. We brought the family physicians because they have a unique position, which we hope that the country in Kenya is going to optimize them. They could be the first center of all the primary healthcare workers in terms of they should be the first line. It's just that now you are in hospital, but they should be able to interact between hospital and community very seamlessly. And I think your organization of family practitioners, the physicians, they are quite trying to bring an advocacy on their role in PHC, even as we look at the community health promoters. But we do appreciate your role. Great, so building foundations. One person, I think it was Christabel or Benta, who mentioned about having a dedicated team or having a place that feedback can be taken by the patient. So I want to hear from Frida and Esther on the role of some mechanism or a team that enables us to just do this patient-centeredness and especially be the recipients of feedback, be the ones that advocate and help the system to grow. And just to hear what has been the experience in your institution and what are the opportunities that we can even do better as a country. And by the way, we are hosted here by Patient Affairs Unit of KNH. Dr. Kalondu, you can wave. Yeah, so Dr. Kalondu is the HOU for Patient Affairs, a dedicated unit towards patient-centeredness. So what has been our experiences in our institutions? We can start with Frida.
Thank you very much. So when a patient walks into the hospital gate, or when a person, let me say a person, because when you walk into a hospital, you walk in for different things. You could be walking in to refill your medication. You could be walking in for your appointment. You could be walking in to pay, some debt that you had for the hospital. And the person who will encounter the provider who will encounter the person who walked into the hospital is very key in gathering information that that person brings. For instance, if a person is walking in for a consultation and they come to me as the family physician, I am the one who will be able to tell if they were here before or where they were before. Like someone else said, they may have gone through 5 other hands and then they're coming to me for a 5th or, the 7th opinion. I am the one who will be able to hear their story and to know what they went through and to know what they're looking for from me. And what I would say is patient-centered care is mainly multidisciplinary, because you may come to me on a very busy day. I know people talked about clearing the queue. It is a reality, by the way, on the ground. Like Lydia said, we have to talk about what is the reality on the ground. So you may come to me on a very busy day, but the nurse there, maybe when checking your blood sugar, may have a minute or two to find out what really what really is going on and what really has brought you there. As the doctor, I may just be concerned about the blood pressure or the blood sugar or what, but really, what really brought you? What are your ideas? What are your concerns? What are your expectations today? And why I insist on the multidisciplinary approach is because when the nurse gathers the information today, and then maybe next week we sit down as a clinic and say, what are some of the ways that we can improve our clinic, healthcare, to better healthcare delivery? I'll be able to hear the nurse's story on what the patient said to them that they maybe did not say to me, or the nutritionist, or the customer care person, or the person taking vitals, doing triage. And so I would say the best way to collect feedback is to take time to listen to every member, the several members of the healthcare providing team and every member in the team, and sit frequently to just hear from one another what we gathered from the patients.
Thank you very much. I hope you have underlined a few things that Frida has said. Esther?
Thank you. So having this culture change, because it's a shift in our attitude in regards to how we offer care, for it to be patient-centered, it's a collective effort. But as Dr. Okutoi has said, there's need to have a dedicated team who are driving these initiatives and supporting the frontline workers so that they are able to know it's easy to assume that you just tell people to have empathy, but you need someone who will guide them. So how does this look like? How do I start the conversation? What kind of language do I use? And so I can appreciate, for example, in KNH there, we have a team dedicated to this. So we have a healthcare quality team, which deals, we have quality assurance. They're also focusing on the customer focus. We have patient safety, who are driving patient safety initiatives. We have patient affairs unit as well. So what this unit does is supporting the leadership, because this vision, as we said, has to start with the leadership. They have the vision. And then now having these implementers who are going to implement this vision, there are mechanisms that are required. It's not just about telling people, be more empathetic, give them working tools, help them to collect this feedback. So in our facility, we have various ways of collecting this feedback. And then, for example, we have the registers where the patients write, or we have verbal feedback. There's a time we used to have a good morning team. So basically this team would just go out in the morning asking the patients what they are doing, if they have any concerns about their care. So this may not be possible for all the frontline care workers to be able to do amidst everything else they are doing. So I do believe that leadership should prioritize having a dedicated team taking care of patient-centered care.
Thank you very much. Yeah. Just to underscore some things that have been mentioned here. The issue of multidisciplinary teams, that care is done using multiple people, and at times they need to be multidisciplinary teams, especially if it is for specific clinics. I don't know that Frida was talking about like the diabetes, but there are multiple levels of multidisciplinary teams. And what did she say? they may tell you ideas, meaning when we interact with patients, we pick their needs, we understand when the system failed them today. For example, somebody in the rheumatology clinic, they could say the clearance process for some specific medication is taking too long. Instead of them coming in other centers, this is done as a daycare, but here we are taking long. It is possible we may not meet that patient to tell us, but people among the team members in that group can be able to give patient experiences and align their efforts together. So there is the top leadership. Esther mentioned about leadership, that leadership has to buy into it. So without us being having it as a priority, do we care when a patient complains? Does my boss frown at this, that I can ignore a patient and it is okay? Yeah, so the leadership and the culture that is there. Thank you very much. Ayub, I want to bring you to the initial aspect that was brought by Frida, that a patient comes and interacts with the system as a first at entry at KNH. They may most likely meet a guard. The next person will be to do with health information. What are some of the opportunities to just have patient-centeredness at that first point? For example, if this patient, it was so decided that they don't need to go through triage, confirm, is this your clinic day? Because you are everywhere. The health information team members are everywhere in the hospital. Yeah. What are some of the opportunities to institutionalize patient-centeredness? Or what have you done this far?
Thank you so much. And I thank my colleagues for giving that background. When a patient comes to the hospital or any other facility, depending on the facility setup and the flow of the processes, mostly in KNH, they will find themselves meeting the health information personnel. And this is a very important team. We have a dedicated department to health information management. And what happens when the patient comes is, first of all, to capture the correct information relating to the patient. I'm sure many of us have heard about stories of patient having issues of identification, but that is why the department and the services of health information becomes very important. So first and foremost, we have to capture the correct biodata. And we have to, as much as possible, based on the identification documents that are provided, either the birth certificate, the national ID, or any other identification documents to capture the correct information, because this impacts on the quality of care. This will impact on the other processes that go down the line. And so how do we ensure that this patient-centeredness is ensured? First of all, we must get the correct information. And this will help the rest of the team to be able to attend to this patient with clear identification of what the patient would deserve to get based on their bio information. The other thing is managing of this information is very key, so that anytime I am a patient and I walk in KNH, I should be able to know that my medical information is accessible, first of all, to the clinical team that is attending to me, and I'll have not much trouble giving my background again because it's already documented. And of course, informing the management and the leadership about some of these cases so that the patient can continuously be given the best care depending on the information generated and analyzed from this data that we capture. And so from beginning to the end, the department plays a very key role in ensuring that patient-centeredness is achieved through information management. Thank you.
Thank you very much. I don't know whether we are aware that the bottom-up economic transformation agenda has the aspects of health information, just digitizing and connecting us all. And it is an enabler of measurement, by the way, because we'll be able to know how we are doing. I don't know, Ayub, where we are as a country on matters a patient and their information, access to the information. Is there any discussions among your health information teams about how the future of patient and their information?
There is a lot of discussion going on in information management, and especially in medical information management, and with the current Data Protection Act, there's a lot of discussion. However, there's also a lot of push towards digitizing health information and issues of access control, because now it has become a requirement that every institution must put in place measures to protect that information that you process and generate, because the data subjects have a right to know how the information they give to the institutions of healthcare is protected and taken care of. So there is a lot of debate concerning data protection currently, and a lot of debate going on concerning digitization so that we can enhance information shareability and information portability. And so the challenge that is currently at hand is, how do you ensure that you have the right information and it is safe? And how is this patient assured that the information is safeguarded and nobody else will access it without proper authorization?
Thank you very much. Those are debates that continue, but they are not just debates, they are being implemented. There's already financing to some extent and action towards the same. Actually, Mwai Kibaki Othaya was within the hospitals that got the highway for health information across the country. They are part of that, but KNH Main, we still have our own local. So I don't know how far it has gone, but it will bring challenges that we'll have to face. If you look at literature, there are comments from physicians that what makes them most disappointed, or is it having burnout? It's trying to make sure all the information is within the electronic medical record. And so in some ways, that comes as, it will come as an activity that we may have to contend with. Maybe Nairobi Hospital and Aga Khan are already having that, but in KNH, the accident and emergency and some areas are fully using the platform. And one of the challenges is physicians being empathetic and not looking at the drop-down bar and feeling everything, because they can't go to the next patient unless you've done that. So when we come to work, they feel there is work to make sure all information is in and time to make sure that they are connecting with the patient. Studies in the US have confirmed that there was some bit of shakeup in terms of patients feeling they're heard, they're being understood by the doctors because they're busy on the gadgets. I don't know, in Tenwek, whether do you have a system, and has it had any impact on patients' perception to their, how attentive the doctor is, how they're listening, because those are the mediums of patient-centeredness, listening, eye contact. By the time I'm waiting for this drop-down bar to come, the other, I can easily get tired. So have there been any impact in Tenwek? Any comments on the use of electronic medical health records and the patient experience, or any concerns?
Yeah, so in Tenwek, we fully use the electronic health system, unless we are having problems with the server being down. On the patient side, I'm not sure, but for us, how it has helped us to promote patient-centered care. When I have a consultation with a patient today, and then I enter, like I key in everything that we have discussed, what brought them, all their issues, and even the non-medical concerns, because because of constraints of time, again, the doctor or the nurse or whoever tends to write what is necessary medically in the system. But then that way you fail the next, the next person who is going to see that patient. Because if I presented to hospital with kidney disease, and my idea of this kidney disease is that it was brought in by witchcraft, and I failed to write that, the next clinician will not pick it up, because somebody talked about emotional support, spiritual support. A person is a whole. So if I fail to write that, if I fail to document that, aside from the fact that we're dealing with stage 3 kidney disease in this patient also has some other ideas concerning their health, their cause of illness. And this is what I did. This is where I reached. Maybe I contacted Counselor so-and-so, or I contacted Chaplain so-and-so. This is where we reached. And we agreed that the next step for care, apart from medicine, is this for the patient. Then I fail the next person, because unless that person brings it up again, like the patient brings it up again in the next visit, which probably they will not, because they feel like they have already shared, and their hope is that they'll meet you again in the next visit, which is not always possible, because you cannot always be there in the hospital. So documenting what your patient tells you is very, very important. Despite the fact that it's time consuming, it's one of the ways in Tenwek where we've been able to, really strengthen continuity of care in that way, incorporate the patient's voice, and be able to address other needs for the patient, the psychosocial, the spiritual, and the context where they come from. So maybe just from your question, I should be able to, when I go back, I'll find out from the patients, what that means for them, how they feel like when they walk in and the doctor who is seeing them, they've never met, but they start asking them questions as if they've met before, because they were able to get information about them. Like I took time to read the last few encounters that you came, and I know that from the last encounter, this is what you encountered. And then I start telling you about you, and already it makes you feel comfortable. So maybe that is something I can, go, find out.
Thank you. But on a positive note, it means the doctors are not feeling, and the nurses, that they're using more time on the computer and less on the patient. But I think it is something worth finding out. And I think it is, the patients, when they come to us, us knowing their information actually could be positive. Every time I don't need to tell you when I was born and how many children we were. I'm 70, I'm still being asked, "Mlikuwa wangapi kwenyu?" And so I think there is some merit. Great. So on matters addressing, finding out where we are, because on any issue, even including patient-centeredness, there's the aspect of how are you doing as an institution. Most of the time we do surveys and we do other expensive or cheap or time-consuming ideas of measurements. I would love to know how that happens in Mwai Kibaki, but I will also take the mic to I'll surprise a few, at least we can get from Benta about how that measurement is done and the metrics and what comments they can give. Most of monthly in KNH, we do summaries that are put together at a quarterly level and taken to the board. Ayub's department, they have a statistics department. And so that statistic department is only most of the time able to take hard data on the disease issues and some processes or some surveys that have been done. However, as we've been told by Frida, the narratives on who this patient is, what they thought, and then now we're talking about how they experience the hospital. That cannot be done by Ayub's group because it is not put there. So we would want to know what measurements, what metrics, if we say we want to improve, what are we improving? And so I think I'll allow, yes, Esther, and then Benta will give us some thoughts on measurements and metrics. Yeah.
Thank you. So what we are doing currently, we've done the customer satisfaction surveys, basically at different checkpoints. For example, if it's the lab, maybe the patient would be worried about the waiting time, the delays of the results. So we put some of those questions that are very unique to every area. If it's the outpatient, we have specific questions for that. Then we develop a customer satisfaction survey that will give us the index of satisfaction. We also have audits on patient-centered care. We can focus on the 8 principles. Maybe it's about pain management. How do patients feel about if their pain is being managed properly? We also do surveys on, for example, doctor's ward round. We just look at the doctor introducing. There are those things that we know the patient would like most of the time. Maybe the doctor introduces themselves and maybe the team. We are constantly engaging the patient, so we just have someone joining the round and sort of just doing a study. So these are things that are ongoing. We have implemented them, especially since the previous time I was here. It was very interesting to listen to patients tell their stories, and that's why we even got that idea of the doctor's ward round. There were a lot of patients feel very strongly about the information they are given during the rounds and how the team interacts with them. Something else that we do that can be towards this is the turnaround times. I think one of the most maybe irritating thing that a patient can experience is having to wait for so long. So we do this for the outpatient departments usually. Yeah, so that is given as a target for every department that they have to monitor their turnaround times, and when there are any challenges, then we have to discuss on how we are going to improve that. So there may be others that have left out, but those are just some of the ones we are doing.
Thank you very much. I think we can have Benta share something from Nairobi Hospital. Then Ann Budhia, I think you're somewhere, you'll share the KNH story of customer focus. What metrics do you think we are using and where are we?
Well, thank you. Sort of down the list, and just to state that she's mentioned a few, but I also have some that I'd like to share. So TATs is common for the clinical outcomes.
Turnaround times?
Sorry, turnaround times. Yeah. Are common for all the clinical outcomes. One is looking at the time the patient spends from arrival to triage to being seen by the doctor, from the doctor to pharmacy to lab. And every section, every stop, every touch point has its own turnaround time, as well as the targeted turnaround time. And this you measure daily, and you have a monthly report to it that goes right through to the top, yeah, when you're giving your monthly report. Besides that, there is a throughput time. So how long have you taken from the time you came in to the time you left? And then going down that list, where was the hurdle? Where was the bottleneck? And why did you stay there too long? That gives you a place to work at so that you can address the challenge that caused the delay there, as well as explaining the wait. Explaining the wait becomes very important because I can wait and not mind waiting as long as I know why I'm waiting. So explain your wait to your patient every time you have that opportunity to do so. And because our patients, doesn't matter where they are, they really want service done and done quickly. If I understand that I will get it, but there is 1, 2, and 3 to do, then I will wait patiently for my turn to come. But besides that, and looking at other patients' feedback, there is the unsolicited data that comes through Twitter, as we're taught here. It comes through all manner of social media platforms. Some of it is very good. A lot of it is very good. And they actually mention your name. They say, Dr. So-and-so at Triage, nurse so-and-so, or the waiter in this ward, or the cleaner in my room, and they say the person's name. Now that information is very, very important. It is sent out to the entire customer service department. The department receives it, but sends it out to the entire hospital so that you know today X was appreciated and X was, and it happens all the time. So if I see that Christina was appreciated today, you get lots of well done from all over the place because we have all seen it on a day-to-day basis. And that's unsolicited feedback. But there is the other that we actually ask for. We came from a questionnaire, paper questionnaire that we used to do before COVID. And it had multiple questions that talked about the environment. But the last question that sought the patient's loyalty to the organization asked, would you recommend this hospital to another person, to your family? Would you come back to us? So even if you've had a complaint from the patient, when you call them in to have a conversation around their complaint, your last statement must be, would you still come back despite what has happened? It means that you've had this conversation, you've acknowledged their concern, you've discussed it with everybody that had anything to do with the patient's stay during that concern, and then there is really it's a root cause analysis. Then you develop an action plan from that root cause analysis, and that action plan must then be implemented within a stipulated time frame. But when it happens in one department, it doesn't mean that it won't happen anywhere. Yeah. So that action plan can then be shared across departments to the heads of departments and say, well, this is what happened at X department. Please make sure it doesn't happen at your departments, so that we learn from an action point from one section of the hospital. But talking about measuring experience, this is outside of what we are doing, which I hope will then come to all of us. The experience measure is a concern that is global. And in the morning, we talked with, I think Dr. has gone, but there is an institute, the Beryl Institute of Patient Experience, that has been developing a global measurement, global experience measurement tool. I happen to be a part of that committee that was seeking to determine whether experience outside of the country would be the same as in any healthcare institution. Because as we said in the morning, it's humans taking care of humans, and experience must be the same here or there. In that tool, it has sections that seek the feedback from the patient. How was your experience? It also has sections that seek feedback from the caregivers, from the nurses and the doctors who encounter the patient. Hopefully, if that tool gets through the testing period, then we may also be able to have access to it. Currently, a few hospitals in Kenya have picked it up. They have accepted to be test sites, and they've actually started collecting data using that tool, and hopefully we'll be able to have access to it as well, the rest of us who wish to try it. So experience and measurement is very important. What is not measured is not done. That we all know. And yesterday I listened to a presentation about experience, and again, speaking to our colleague here, and the use of AI and interpretation of data. When you make a phone call to a place, you're always told this conversation is recorded and maybe used to, that information that the telephone operator picks, especially the patients who do not get helped, that information is stored. That is information that can be harnessed to give you feedback about what your patients who call into the hospital daily feel. Because the use of AI enables us to not to isolate the words that said from the feelings that the patient had during that conversation, so that you get to know what else you need to do in the patient directly. So I think I'll do that.
Thank you very much. Measurement is very important, even if you measure just a small aspect. And if you consistently measure, then you can know your trends. Is Anne around? Anne Budia? Is Anne Budia with us? Great. So Anne was supposed just to give us, I would have loved her to situate the patient-centeredness and how that falls in. Some institutions have what we call quality management systems. The Aga Khan has JCI. We have the Nairobi Hospital, you have SafeCare? Or JCI? QMS? Okay, the ISO 2015, yeah, great. So those quality management systems make the hospital at some point to stop and see, are we measuring, are we monitoring, and in a routine manner. They are called actually a knowledge management systems because they enable you to see and to work on what you have measured and to come back again and see whether that worked or not. So it is very important that as an institution, we have metrics. The bank at times just has you to put a smiley face or not. It may not give you details, but we may know how we are doing. So I think measurement for patient-centeredness and determining what metrics and what specific aspect of care. And for a system that is learning, it means that we are cascading that to everybody, whether it's catering or the nurses or the doctors. I think I'll go back to Ayub and just to get to hear. Yeah, when we talk of the measurements and metrics and all these complex things, at times they're not easily translated when you do not find them in the patient's file. If we tell you we want to hear ABCD, is there anything within the domains that is happening currently before we get the tool that Dr. Monge, Mr. Monge is talking about, before we get there? Is there anything within our scope that we are using to know where we are at a global, at a level that you, the health information team, can decipher? Because in KNH, each department does a customer satisfaction, but we have metrics. Is there anything that you think we can rely on? Or do we just continue doing the one-off? The good thing about health information is once you inculcate something in their system, they do it routinely. They will give you monthly, quarterly. So what do you think we can do to become more reliable in just getting some of this information? And is it data that you can get, or it isn't possible?
Thank you so much. Maybe just to mention, currently KNH is gradually automating its information management system. And the question is, what are some of the metrics? My colleagues have mentioned a few things that are being done, which we as KNH also do. Of course, we have the customer satisfaction surveys that we conduct, but we also have the clinical indicators that are normally generated from the data. And these clinical indicators are able to help management to be able to make very key decisions concerning the care that is provided. These clinical indicators include mortality, infant mortality, we have maternal mortality, and most of these are even anchored into the WHO global indicators of in healthcare. And so as KNH, we have those clinical indicators that we monitor on a regular basis. We look at the average length of stay in respective specialties to be able to just give an indication of what is the kind of care that is being given and how long are patients taking for them to get out of the system. So we have those regular indicators that we give every month, weekly basis. We have operational reports that we give to management and to the clinical team. And at the end of the day, we are able to also report how the facility or KNH is performing to the ministry through the same data that we collect and analyze. And so apart from the normal quality management system surveys that we do, like the customer feedback, we have the quality audits, we have those specific indicators that we are able to generate from our data that we capture. And this, I would quicken to say that it's based on the accuracy of the information that we document. Because this patient passes through our hands, all of us, from the health information to the last person. If we cannot document the correct information, then at the end of the day, we shall not have the correct indicators of what our healthcare system is doing and how it's performing. So my plea to us and to all of us out there is, first of all, let's document accurate information. Let us be timely. Let us be able to be comprehensive enough so that this document you are making, or this document that we are passing on to the rest of the healthcare team, is the communication tool. Professor Chokwe may see a patient, but the physio will never know what happened unless it's clearly documented. Is the information comprehensive enough? Are we passing this information to the right users for effective translation of that information to impact the patient care? Are we able to segment the information and give it to the right groups of people in the team? So that is what I would urge for now, Daktari, and to all the players, that let us document and document clearly for the care and the patient-centeredness of these customers. Thank you.
Thank you very much. And that is part of what we call a learning health system. A learning system looks and reflects and does something about it. But now the bigger challenge is whatever we get should be able to be shared. That as a team, we have a common outcome or a desired destination that we'd want to improve on this or to adjust this. So thank you for the information. And so it is up to us to determine what in all these forests is useful for patient care and what is useful for patient-centeredness. And as we take the various approaches, there's always cost and time. The same people who are doing the customer satisfaction survey could be the same ones to provide care. So there is that balance, and the use of technology. We've been told by Benta, use of AI. So let us open up the space for feedback, and let us have some, we call it passive collection of information. IUB enables passive collection because they have the patient records. So what can we collect passively all the time for the purpose of knowing where we are? So we'll just get some few questions, maybe 2 questions, and then we get 2 wrap-up comments of what we have picked from this great symposium before I hand over. So Paul, you'll help us? Any 2 questions? And then I'll come to Prof. I'm of the opinion that I think we should include patient-centeredness in both aspects. It's called Bloom's taxonomy of learning. We should both give the theory, then they should be able to appreciate up to applying it. Just imagining that I will see how Prof. Chokwe talks well to the patient and palpates for tenderness gently without having been taught that that's actually a patient's right. You need to engage them, to involve them, and it has better outcomes. It can make a difference. So I think we need to raise the bar, but I will get a comment from you. It is not enough for me to just see this Prof. Chokwe does this thing very well. We need to be trained, and both pre-service and as in-service. We're already in service, and some of these terminologies, patient-centeredness, I don't know whether you got it before when you were in a KMTC. Quality improvement, patient safety, reduction of harm. So I would want a statement that moves in the right direction concerning training, but when it comes from the horse, then we hear the mind better. Yeah, so any feedback, question to these panelists or any comments we can take 2. Then there's one here.
Okay, thank you. I think maybe let me stand. Thank you so much, I think, for talking about very important things, especially feedback collection. I just needed to share some things that happening, especially one of the challenges, and maybe for this team as we go ahead, is benchmarking. Because most of the time we each set our targets as institutions. And I think as healthcare, it's a problem within the country that we need to probably look at, because when we say maybe my net promoter score is about 90%, what is my benchmark? I'm using the international benchmark. What is my local setting? I know we do have lots of researchers around, and maybe those are areas that we need to get together. Can we be able to share this patient experience scores and have a targeted benchmark? Now, my second thought is towards maybe just incorporating AI and listening to the patient's voice and working on patient-centeredness, even as we implement digital solutions within our organizations. I do know that in about the last 2 years, maybe 1 year, we are 1 year and 3 months, the entire Aga Khan and its 52 centers are now rolling out to Aga Khan, Kisumu, Mombasa, Dar es Salaam are getting onto one platform where, you know, all patient records are going to be documented. Does it spend more time documenting? Yes, there is. A lot of time is wasted and contact with the patient definitely is lost. So there's a lot of education to get the patient on board and, you know, just make them understand the initial consult will take longer than their normal consultation. But then there are other ways that you can do it when implementing. Look at solutions like voice recognition methods where you don't really have to type, but get the voice recognition and edit it. Use AI to be able to make your work easy. And I think one that really makes me very happy during the documentation is the patient portal. This is really where patient-centeredness is key, because when you have a patient portal, on my phone, I can be able to look at all my medical records. I can be able to look at my results. I don't have to go to hospital to check on what the results are. My medications are in here if I forgot. My appointments are on my patient portal. So just some of the thoughts that we can be able to incorporate so that we can make patient care and patient-centeredness a focus in all that we develop. Thank you.
Thank you. It's exciting to hear about the patient portal because patients have a right to their information. Still, even with the patient portal, the healthcare provider will not sit back and say it is the information because it can be misinterpreted. So we'll still have a role. The bar will be set higher on explaining more. You've heard of some people with a blood group O positive and they come, nimeambiwa niko na positive kwa damu. And the only positive thing they know is one. So it means as we get the technology, as we get the efficiencies, there are more patient issues that may come up and we may need just to address. At times, it may be a learning curve, but it is worth it because it has more merit. Yeah. Yes, Karim.
Yes, my question goes to Remy and the other team members.
I am the one answering questions. That was a comment. You will give us a comment about it after we finish.
We know, most of the SDPs, the service delivery areas, the patients or clients are given bookings. And in areas where there is automation, they are booked online. But do they ever remind the patients or the clients when they are supposed to come back? Because they are given the date and maybe the client can forget. So whatever they document, do they communicate when the client is to appointments? The other one goes to the note from the doctor from Pennek. Yeah, she said they usually share the information with the team players in their facility. But you wanted to know whether that feedback, whatever they ship, to go back to their clients or the patients. Yeah, that happens too.
Great. So, Frida, you'll handle the one for Tenwek, but about the comments that came from Christabel, any of you can respond.
Thank you very much for those very insightful comments about reminding the patients of their appointments. In Tenwek, for example, we used to have a small sheet that is written the date of your next appointment and the labs, what we will need from you when you come in for the next visit. But then we realized that some people may lose or drop that paper before they leave hospital. And so they forget when they were supposed to come back. So we incorporated it in our EMR so that the phone number that you have registered with, like Ayub said, the information that you give at the point of entry has to be correct because it will impact your care today and subsequent care. So what we do is that the number that you have registered with, we confirm it with you. And then I schedule an appointment for you. And then immediately when you're still in the room, you receive a message of your next visit and what is required of you in your next visit. And then a day before or days, like 2 days before, you get the same reminder for that. And then about whether the information that we share as members of the team gets back to the patient. I think like there was a comment here that if we don't measure things, we do not know whether they work or not. So if we sat down as members of a certain clinic and then we figured out this was a problem for this patient, and then we write it somewhere, and then the person who sees that patient next does not address it because, like you said, we don't have a way to measure or a way to make sure that information gets back. Then it may not be communicated. So to be honest, we have not monitored that. And maybe it's something that we can take up so that it can stop, so that it can not just empower us as the healthcare providing team to offer better care, but also that the patient can know that we are concerned about what really brought them and what really was the expectation of us. So yeah, just learning from this seminar is that we should always find ways to make sure that things are, objectively assessed.
Maybe I can just comment on the patient portals. So for most hospitals which are being run by the government, I know there's always the constraint of resources, and we are still in the process of getting to a point where we have digitalized our services. So I feel for hospitals, maybe, for example, us who are still using paper, we can still go for a different innovation, have some open records for patients to do that. We have not yet implemented that, but it's a good idea. So I think we can still find something that works for all of us based on the resources that we do have. Thank you.
Just to also comment first on the benchmarking. Yes, we can benchmark amongst ourselves as institutions. I would want to know how Nairobi Hospital is doing and how Kenyatta University is doing, so that if there's anything I can pick from there, that is okay. However, I would also say that standardizing the practice across so that we have a common focus on where we want to be would be another way forward, such that if a certain process is to be performed as per a given international standard or local standard, then we should all strive to achieve that. So that if how I document certain information should be the same someone else documents elsewhere. And shareability of that information becomes very easy because we are looking at it from the same point of view. The other thing I would want to comment is about EMR, electronic medical records. Yes, there are pros and cons. One may feel we lose contact because you concentrate so much on the gadgets, but then there's a positive side of it in terms of look at the costs implication when it comes to a patient being referred from Othaya or Kakamega, and they have to repeat same investigations again. It has very positive impact in terms of costs cutting for the patient and reducing the out-of-pocket expenses. So the positives more or the negative? You can look at it and see which is the best way to go. But I would recommend that having an electronic system that allows sharing of information across facilities, it would also help in standardizing the practice. Maybe just to comment about the booking. Yes, we have manual booking that are still being done. But as I said, we are automating the systems, and automation of a system is gradual because you have to run both systems and monitor until you know that the electronic one is stable. So the system is able to onboard a reminder system that will be able to send reminders to patients so that they don't miss the appointments because they forgot. Because some patients actually forget to remember the appointment. So we are confident that once we are fully electronic, that particular part of the system is going to be onboarded and reminders can be sent. For now, we have the appointment card system, which reminds a patient on the return date. About the other issue about the portal, it's the enabling environment that really is key. If we have an enabling environment for both the customer and the service provider, then the portal becomes a very good way of engaging the patient, even in providing their information, and even they can even suggest a request for booking online or change of booking. And that would be a good thing for us.
Thank you very much. We are almost winding up. I don't know whether we have any patients or a patient representative or family, not really healthcare worker. We are all potential patients and we may have a patient, a family, but allow me to just have one of us to give a comment. Nabwana is our good father to our patient in the ward.
Thank you. Imekuwa poa and I appreciate for the opportunity. Mi na mgonjwa hapa KNH. I'm from Mombasa. Na the information ambayo nimepata hapa ni information ambayo itanisaidia going forward, na pia I'm also an advocate in some fields. So pia itanisaidia kushare na wengine ili ujumbe uendelee kuenea. Otherwise, asanteni sana Patient Affairs Unit na nyote kwa yale ambayo mnaendelea kuyafanya. Asante.
Thank you. So Nabwana needed a conversation and Patient Affairs welcomed him and they were able to have a conversation. He's now very okay. Whatever challenges were there, zimesaidika. And so we are not fake, we are real. Thank you for showing evidence. So we address or we support the hospital. If a patient thinks or a family thinks the hospital imenikosea sana. These good nurses here will tell them, go to Patient Affairs. We are above National Bank, number 28. The Patient Affairs unit is a unit within patient safety, and they support patient-centeredness. They do surveys, they work with the patients and support family conferences. There are times the ward is too hot for a family conference to happen. They ask for reinforcement, and the patients are happy to come and see people not putting on dust coats or white uniform, and they breathe in and out. And sooner or later they discover even the carers, the caregivers are also human and they're willing to talk. So this is a human transaction. And so we need to humanize healthcare. So we'll get some parting shot from Prof. Chope. I want you to give a statement that it is important to train on patient-centeredness.
I said this in the morning. I did not know what I was coming to do.
Yes, that is why.
This journey started with a midnight call. And it's not ending. The most basic statement of what I am going to say. If you are a teacher, your success is not the A's in the examinations and the celebrations people are having. Your success is the achievement of your students beyond what you have done. They go further, they create things, they innovate and produce newer things and solutions to the problems that you have taught them about. Then you have succeeded. in the basics of what she was talking about, blue stocks is just remembering. I told you my name is Choco. When you live here, you remember my name is Choco. If you're more creative, you go and find out what is this Choco thing from. You go research where does these people come, what do they do, what can you make it better. Then you have moved on to a different phase of life. That is what education is all about. And that is what we're trying to do as far as medical training is concerned. When you leave nursery school, you can repeat your name, A, B, C, D, E. When you move from 4, you can draw the diagram of the whatever you have dissected and the likes. When you come to medical school, a patient gives you a problem, you translate it, then you go to your internship in your treat. When you become a researcher, you produce solutions for the next set of things. What are we doing? It's not just me who's going to be beside the patient showing people how to do things. These things must be procedural, must be recorded. We have things people in medical fields now called SOPs and the likes that must be followed through. But we might not be able to teach everybody the same processes. So we have incorporated as well technology into all these things. Simulation scenarios in which now the same things are repeated by everybody every day in certain spaces. These things are expensive. The same thing with the technology we are talking about, medical records and the likes. It does not necessarily make your work cheaper or less. We must remember technology depends a lot on our input, our interpretation of what we are putting into that technology, and the guidelines that they give us. Some of the things that we're putting in are probably more harmful than what we're helping. So simulation labs are coming into place, and we're helping our students pick up these techniques of the way that we think is the best practice. Medical records, as you're trying to say, you have a platform that is linked to the system with all your providers and everybody else. We've got several things, the data protection, the issues of hacking, shutting down systems. How are we able to protect everybody else from that? The burnout is real, it's global. People are tired. The insurance company wants 10 pages of medical statements from a patient in ICU every 2 days. Which doctor is producing that? The nurse has to take blood pressures and blah, 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 blah for 10 patients and has to key in that also. Why aren't we integrating the gadgets that are taking these measurements directly into the information system? People just simply say, I went to school to take care of a patient. I didn't go to school to become a data. And this is printed out in current journals that people are walking out of health systems because their job description has changed. Because the people who are managing health today are not the doctors or the nurses. They are managers somewhere else who are looking for reasons for who was that person with many P's who's disappeared? The payer. The payer is looking for a reason not to to make payment. So you miss one full stop and they say, yeah, all right, we know that because of course existing scenario, therefore we're not going to pay. In this country, the social media is also giving us a lot of other information. They'll tell you the nurses are no longer complaining at work because they used to complain. They are studying for their next exams online. So whereas you think they're putting in data for your sickness, they're actually doing their next assignment. So they are very comfortable with your gadgets. So that is the other effect that's happening out of the whole system. So it's things to think through as we go through all these things. And when we want to have all these things, let's identify champions. There are people who are naturally gifted or drawn to some of these things that we are asking everybody else to do. I am not interested in putting IT, computer, pictures and the likes, but the university expects me to have a website with all my activities every day and pictures. I am happier sitting with a very sick patient for 12 hours. When you give me a computer for 10 minutes to give you pictures on a website, I will not do it. But if you give me somebody who I can tell, these are the pictures and these are the stories behind them, I will facilitate. So we must identify those champions. The same way schools identify characters and potentials of people who can be musicians, people who can generate things for us. I don't know whether you people actually notice. We mentioned this in the morning about beautiful buildings as hospitals, and nobody thinks of what's happening in the hospital. Has anybody noticed anything about KNH? The gardens are spectacular. And there's one person in this hospital, you must be able to identify him. He's very invisible, who does all this creative work. If you send him somewhere else, he will not be as productive. And when you come to the hospital and you see a beautiful building, part of your problems are here. If you come and see a dilapidated building and you're thinking, do they even have sterile syringes in there? So despite this perception that all these beautiful things, it's a starting point. We're getting beyond what was previously known as bad. Thank you.
Thank you very much, Prof. An applause for Prof. And thank you for crowning it all. So thank you, Frida, Esther, and Ayub. Give us your parting shot in a minute, and we will be going for lunch soon. Thank you.
Thank you so much. I want to appreciate all of us for just giving us your attention and being able to get our side of perspective. And what I would want to say as a parting shot is health information is a very valuable asset that we cannot do without. And let us ensure that we capture it the correct way, have it accurately captured. Please, for our clinical team, document what someone else will be able to understand. And something that can always communicate and make sense. Number two, let us ensure that it is comprehensive, it's timely, it is what can be supported or factual. Let's not just document for the sake of documenting, because that will impact what decisions will be made about the care of our patients. And if we are talking patient-centeredness and patient-centric, then let us have the right information. Let us always have time, spare time to document the right thing. And let's not be in a hurry, because we need that later on to make important decisions that affect the quality of care. Thank you.
Thank you. My parting shot would be that I think we just take time to really understand how patient-centered care really has a positive impact on the healthcare outcomes that we have, so that when we maybe give an injection the standard way, or we give patients the medication as we were taught, do we think of, will they take that medication? We try to think beyond that small setup. And I would also maybe challenge all of us who are in healthcare to start looking at measuring those outcomes that are beyond the health system. For example, how often are patients readmitted? Does that have something to do with how maybe we discharged them or something of that sort? And sort of sharing that vision. People usually change when they feel something is very important. So people don't want to feel like this is just another thing they're telling us to do. Do they really believe that me greeting a patient or addressing them in a particular way will change the healthcare outcomes? So let's be agents of change, and also let's model that behavior. It's not easy to change things when everybody else is doing something different. For example, let's say you're in a ward round and somebody just comes and starts maybe inspecting the patient, and that is your senior. Most people will usually do what that person is doing. So we can model these behaviors that we feel are going to impact the patients, and probably we are going to change the culture in time. So that's it for me. Thank you so much for your time and attention. Thank you.
I would say that whatever you do it with all your heart, as though working for God, not for men. And as she said, medicine and what we do as healthcare workers is mainly learned by apprenticeship. There's the science part, but a lot is based on what I see every day. Like some of the skills, some of the examination skills that I have today, I saw a teacher do it before. And so as from where I sit, like as a doctor, that encounter that I have with the patient, I should be able to make the most of it, because as part of me doing my best for my patient is me being able to give my best from my training, as in that is the science and the education and the empowerment that I give to the patient concerning their condition, but also allowing them to speak out their concerns. Because I may end up addressing what I think is the most life-threatening thing, but they may end up living as the most dissatisfied person. So do your best as part of the members of the team, so that we can offer the best as those having our master in heaven, or whoever your master is, and not for men or our employers. Thank you so much. I have learned so much, I think even more than I have shared, and I'm so grateful for this opportunity to be here. I hope to attend to many more and to take back to my facility all the things that I have learned today. Barikiweni sana.
Thank you very much. I think they have done a great job. We can give them another round of applause. Thank you. I think we've come now to the end of our panel session, and we are healthcare providers. So there is what is there for us when we give patient-centered care. You're more satisfied. You go home feeling like you've interacted at a human level. So there is benefit even to us and to our families. Yeah, you go back a more positive person because you did something that was touching a heart. It's just that God gave you the tools, the skills. And so really this year we've focused on just having the healthcare workers, but it's very important that we are the ones who can benefit even as we extend this to the patient. Allow me to hand this back over to Charity to give gifts, and then we have a vote of thanks by Mr. Mwiti. Charity, you're welcome. Charity works in patient safety. She's a patient safety expert. Charity Kianji.
Thank you, Dr. Lydia. I didn't have a speech for today, but I would like to thank the panelists for taking us through this section. The ideal environment for our patients, indeed, patient-centered care environment is the only way out. We need to be compassionate. We need to have empathy for our patients. We need to be responsive for our patients. As our panelists have told us, we also need to respond to the needs and values of our patients individually, not as a group. So we also need to remember to respect our patients. So thank you so much for sharing with us your experiences, the opportunities for improvements. I'm sure we've learned and we're going to walk the journey. So receive our token of appreciation. It's a small gift to take home for your memories, and we look forward to meeting and inviting you more. Thank you. So we can have Dr. Frida, the family physician. She's done us a great work. Thank you so much for taking your time. Welcome again. We have Esther. I'm holding the mic now. Okay, thank you, Elizabeth. Thank you so much, Esther, for the good work. She's a quality coordinator. She's done great work in Moi Kibaki with a lot of energy. Thank you. We have Ayub. Ayub is from our health information. He works behind the desk, but he does great work. Thank you for coming to share with us. He's a patient-centered champion. And I think to thank Dr. Kitoi, we can also give you the last gift we have. There's one, I think, who hasn't gotten the gift. We have one. So that you don't walk out empty-handed. Yeah, thank you for being a very good leader. Who's actually very passionate about patient-centered and patient safety and general equality. Thank you so much. Welcome again.
This juncture, we want to invite Dr. Peter Mwiti, who is one of our staff here at KNH and also representing research and programs. He's one of our hosts here, and we are very proud of Dr. Mwiti, who will give us a vote of thanks. Thank you, team. We don't take it for granted for you being here from morning up to this time. First, we start by thanking God for this opportunity he has given us to discuss from morning up to now about our patient. And mostly we have learned today, we are the patient. And a big point we are going to say is that all of us, we have a great role to play for our patient. Therefore, accept and appreciate what you do. First one, we thank Dr. Kim Tai, who is representing the principal secretary in the Ministry of Health. He has given good word about encouraging us and putting across how important we are in provision of the patient care in the country. We also thank Dr. Wafula, who is representing our share of KNH board. He has given us opportunity to be here together with Everson Kamuri, who has given this opportunity for us to be here, allowing this venue to be used, allowing everything to be done here. We don't take it for granted. Dr. Oktoyi, when you go back, tell him that we appreciate this team have run a lot. Also, we thank Dr. Nyabando, who was representing our Senior Director, Clinical Services, because he is the one who is dealing with the patient. The clinical part of it is very important. We cannot do without that. Therefore, we appreciate the team. Also, we appreciate all other team, all the panelists who has been here presenting from morning. And also, before we continue, Professor Shoko was representing University of Nairobi. He has taken a lot of time. Majority of the staff in KNH know how humble he is. We have worked with him in theater for many years. I know how committed to that patient. We used to say, is it the one, the professor dealing with this patient, this kindness? Therefore, I know even from our friends from Aga Khan University, Nairobi University, they know the dedication of that. Even when he has been here, we don't take it for granted. Also, the next thing is that all those people have been here, giving the one as our panelists, asking question, trying to answer 1, 2, 3. All of you, we appreciate. All the country representatives from respective areas, we say thank you. If the people are coming from Tenwe, coming to here, mean that it is a good thing. When you go back, please, not take it for granted. Say, we have said, thank you very much. All the Nairobi County, all Kenyatta staff, we say thank you for coming here. Any other person who has come here today, whether in online, virtually, or here, we feel appreciated. Next, those people who have organized this, Dr. Ktoi and Dr. Kinudi and the team, we say thank you very much. All the administrators who has been assisting us in respective area, from this item we are using Kinarono here, catering, security team, media, please, we don't take it for granted. We say thank you. And any other person who thought that he has done something or he wanted to do something, even those who have prayed for us, we say thank you. We don't take it for granted because this is an opportunity we have. Therefore, as I heard, because I was to hand, any other person who have forgotten, please forgive us. Forgive us so that we can continue. But I will ask everybody to stand up. So that we can get a blessing from one of us. Betty, come and pray for us, please. Betty is a pastor of our patient in respective area. Pray for us. We go for food and we close the meeting and we appreciate you. Mbete, karibu.
Thank you. My name is Betty. As you've heard, I'm a nurse in Kenyatta National Hospital, Orthopedic Department. Let's give thanks to our God. God Almighty, in the name of Jesus Christ, we thank you for this opportunity that you have given each one of us to come and meet here, to come and learn more. Thank you for the knowledge that you have impacted into us. Dear Father, may you help us to go and share it with our patients and with the rest of the staff members, oh God, for the betterment of service to the humanity, oh God. Dear Father, how we thank you even for the leadership of this hospital, for giving us the opportunity to come and be trained here. Thank you for the organizers. Thank you for the rest of the hospitals that have sent their people for us to be a team, even as Kenyans, ready to serve our patients in a patient-centered way, oh God. Thank you because you've told us in the Bible that it is important to have knowledge, because without knowledge, God, we perish. Thank you for the knowledge that you've given unto us as we have committed our lives to serve these patients. Dear Father, may you continue to protect us, continue to bless us, even as we part from this place and go back to our places. Dear Father, we pray for thy protection as we go to our homes. Also bless our families, bless us all. In Jesus' mighty name, we do pray and give thanks. And now may the grace and the love of God and the fellowship of the Holy Spirit be with us now and forevermore. Amen.
DJ who makes your mama twerk. DJ who makes your mama twerk. Yeah, you know about me, baby.
Unfortunately, this time round we didn't.
I stay high on them, steady on my grind. You know, fear no one at all. So do I did last time. Energy 100%, and them no fit comprehend, and them no fit understand. Action flights and take my thoughts. Nobody better than I. 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 Nobody better.
But say to so you go in the business of life. Yeah. Enemies don't need to friend enemies, so just to survive. Yeah. But the devil on my back, that's why I'm steady on my grind. You know where I'm from, I'm never going back. Yeah. So give me one for you. Make sure you feel my body and soul. Pray for the best, if the rest to follow. Blood in my eye, go bless me, go no, cause the point to go no. But the devil on my back, that's why I'm steady on my grind. You know where I'm from, I'm never going back. No, 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 no.
Nobody better than I. 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 Nobody better than the road. It's good. No darling. 4 4, 5 star. It's not. It's plenty. We flex every day, but more money, more blessings. Digest, body reflex. We just don't test me. Don't test me. Eight.
Oh, I'm so steady.
Baby, from my command, like zombie. Go down on me, oh, with your coca body. From my command, like zombie. Go down on me, oh, with your coca body. Cause it's your milky for front enough for me. Hold on for me, I no go to me corny. And if you're looking a fighty, I told me to look. Gelato, oh baby, sumoyo, di. Baby, gonna. Waka, when you enter my licha. Baby, gonna. Will you give me sugar, wala. Macho Mona Lisa, 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 Macho Mona Lisa.
Girl, I'll be foolish if I don't let you indulge me. Your lips like poison. I take my chance with you. If I did, I look happy. You don't know what I feel like. You're in the night. I'll show you I'm loyal. You want that one way down like tsunami. What I feel like. Wow, eh. Would you hold me down? In the corner. Waka waka when you enter my little
Mr. Kevin Kimel, kindly to come to the tent.
baby gonna give me sugar, wahala.
Deadly dead.
Stanley. Macho Mona Lisa, Macho Mona Lisa,
Tell me, Baby Daisy.
Macho Mona Lisa, Macho Mona Lisa, Macho Mona Lisa, Macho Mona Lisa, Macho Mona Lisa.
Ni dead.
Sand.
Ni mix dead.
Master deadly
Master deadly dead.
Dead. Trau dich an einen sprudelnden Ort. Erlebe den aufregendsten Kick.
Deadly dead.
Und gib dich deinem
Master
Verlangen. Wie den neuen unwiderstehlichen Geschmack.
Na imesemekana watu wa Nairobi.
Watu wa Nairobi waingia kwa
Utaingia
laini.
pale kwa
Now
VIP.
listening to an official
Nyinyi wenyeji mnajua vile tunapatana nyuma ya tent.
Watu wa nyumbani wapatane wapi?
Watu wa nyumbani tupatane nyuma ya tent. Wa Nairobi wameenda
Watu wa Nairobi
kula nyama. Mwatayarishie githeri ingine safi pale nyuma. Tutapata.
See, I cannot be myself. I just want to find out if I'm dead.
Maya.
But my body is going, and my body is silent. You leave me at home. And my body is silent. You sweet man, but you. Problem in all the finish. You can try to enjoy. I know the finish. You can try to enjoy. Sekata no the finish. You can try to enjoy. Problem in all the finish. You can try to enjoy. We dance like Luala. Luala. We dance like Luala. Luala. We dance like Luala. All because of you, I be on the phone all night long. Don't be smart when you do to me. Oh no. I be on my business, shawty, but you be on my mind, shawty. Let me pull on my honey, kiss me to the cellular, kiss me to the phone. Can't you see I'm into ya? Can't you see I'm in love? Kiss me to the cellular, kiss me to the phone. Yeah, messing with my medulla. I can't talk alone. Oh no. Emiliano, no. Emiliano, no. Yo, Emiliano, no. My Emiliano, no. I wanna know what it feel like.
Tonight I wanna hold you close. I don't wanna let you go. Loving you is all I know. Yeah. Look into my eyes and tell me why. You got me paralyzed. You got me feeling so alive. Ain't no surprises. On our way, we don't waste time. Got my hands laying down on your waistline. Can we get low? If you let me take you for a ride, you'll memorize it. And I don't want you close. I don't want to let you go. Loving you is all I know. I don't want to dance alone. Let the music take control. Let all of your problems go. If we never make it home, I don't want to dance alone.
Demaya, tunaomba your audience sasa tengeneze sound tafadhali. Sound ni kidogo kidogo
Even if it's only for a night, it can feel like a lifetime. Could never ever tell you lies. Your touch is righteous. On our way, we don't waste time. My hands ain't down. It's not let me get along. Even if it's only for a night, let's make it time. The night I want you go. I don't wanna let you go. Loving you is all I know. I don't wanna dance alone. Let the music take control. Let all of your problems go. If we never make it home, I don't wanna dance alone. Don't wanna dance alone. Don't wanna dance alone. It's your hand on my face. Once we started, we can't stop. It's your hand on my face. It's I don't wanna dance, I don't wanna dance alone. It's your hand on my face. Once we started, we can't stop. It's your hand on my face. It's I don't wanna dance, I don't wanna dance alone. Tonight I wanna hold you close.